Good afternoon, ladies and gentlemen. I hope you can hear me well and see me well. My name is Liliana Stolarczyk, and together with Una O'Connor, I have the pleasure to start the second day of EURADOS Winter School, which is dedicated to the fetal irradiation. Yesterday, we had really excellent talks, and I would like to say thank you one more time to all the speakers. And today, to warm you up, we prepare a few questions. The answer will take only a few seconds, so please take your time and answer to the poll. Kirsten, could you please start? So first question should pop up soon. It's a question about EURADOS, and it's a tricky question because if you are not a member, you are more than welcome to join us. And the second question, it should come soon. So the second question is about your working place. If you can indicate it, where do you work? That will be very helpful for us. The third question is about your position, and we are very interested. What is your position? And that will help us to know to run the discussion after the session. And I see that the answers are coming quite quickly. So we can go to the next question. And this is about your experience. We would like to know if you have in your working, as your working experience, if you have ever had to estimate the dose to the fetus. So please indicate yes or no. I see the answers are there. So the next question, please. And the question is about how many cases per year, if you could indicate that, if it's between 1 to 3 cases per year, if it's 1 to 3 cases per 5 years, or maybe it's more than 3 cases per year, or you don't have an experience. And I also see that we have answered there, so thank you very much. So now poll is closed. Thank you for participation. And just a few announcements before we will start with the first speaker. We have a chat and question and answer. And chat is dedicated to a conversation and to technical problems. And question and answer, it's dedicated to questions you would like to ask the speaker for. And we made a small adjustment to our time plan. To avoid any technical problems, we decided that speakers will answer the questions just after their talks. So we will give extra few minutes for that. Please ask your question in the question and answer, and we will be happy to provide them to the speakers. So let's go directly to our first speaker. This is Dr. Aisling Snow. Dr. Snow is working in the Children's Health Ireland. She studied medicine at the University of Dublin. She got fellowship in the Pediatric Radiobiology in Boston Children's Hospital, Radiology in Boston Children's Hospital, and she was focused on the fetal imaging. Currently, she is planning the new radiological department at the New Children's Hospital in Ireland. So, Dr. Snow, the virtual floor, it's yours.
Hi, thank you very much, Liliana, for the introduction, and thank you to EURADOS for inviting me to speak at this conference. I'm going to talk about a radiologist's perspective on protection of the fetus in a pediatric hospital. Sorry, here we go with the slides. Brilliant. Okay, so our pediatric population is a very distinct population of patients, and what I want to bring us all through today is really a way of thinking about how we sensibly interpret medical exposure regulations for these patients. So how can we apply some logic and data to optimizing our practice and making sure that we're doing the right thing? As you're all much more aware than I am, we are operating under the EU Medical Exposure Regulations, EU Directive 5913, which are the basic safety standards for protection against dangers arising from medical exposure to ionising radiation. In Ireland, this is interpreted into Irish law under Statutory Instrument 256 of 2018. And I'm sure the same has been done in all of the other member states. Oops, sorry. Okay, so the way we've transferred this into our law, it's under a section in the statutory instrument called Special Protection During Pregnancy and Breastfeeding. And under this, it states that an undertaking shall ensure that the referrer or a practitioner, as appropriate, shall inquire as to whether an individual subject to the medical exposure is pregnant or breastfeeding, unless it can be ruled out for obvious reasons or is not relevant for the radiological procedure concerned. So as you can see, not very much guidance given to us within that statutory instrument as regards our particular patient population, which is young girls. So what are the aspects for consideration from my perspective as a pediatric radiologist? There are certain things that are obvious. We need to consider what is our legal responsibility, because we're trying to follow the law as written down, as required under the EU directive. What is my clinical responsibility to the patient? How do we think about the impact on the fetus if exposure occurs? I'm not going to speak to you about that because you're all much more expert in that assessment than I am. What is the liability if an exposure does occur? And that lies more with the hospital and the institution, but also with the consultant radiologist. I'm also interested in our workflows. So how does this law and its interpretation impact how we work in the department? It may impact how many patients we can get through the department, depending on how we have to ask these questions to our patients. So what I'm really most interested in, and what I have here in red, what are the patient factors? So how does our particular patient population need to be thought of differently with regard to this legal requirement? And is the question worth asking to these patients? Okay, so as a pediatric radiologist, so not as a medical professional, but as a pediatric radiologist in particular, how it applies to my patients is different in that my patients are vulnerable. Okay, so these patients are of an age that would be considered to be vulnerable witnesses if they were involved in a legal process. So vulnerable witnesses have to be questioned differently. And some of these, the reasons why that is apply also to the question that we're asking them about pregnancy. And if you look at the evidence, we know that children who are pregnant are likely to respond that they are not if you ask them, for a number of different reasons. It could be because they don't actually realize that they are, even though they are pregnant. And that may seem not to make sense, but it's true. They might reply in the negative because they don't have the capacity to understand that they could be pregnant. So whereas an adult would understand that there is a chance that they could be pregnant after intercourse, a child may not understand that that's the case. They may also answer no because they're embarrassed. They're being asked by somebody who they don't know, who they've just met, beside a parent or guardian who they may not want to answer in front of. Or in fact, maybe they do understand these things, but they're hoping to legally protect the boy or man involved from being in trouble or getting into legal difficulty. So all of these things together render the questioning of a minor very unlikely to return the intended result of a patient owning up to the possibility of being pregnant. The problem is that the law as written and as directed by the EU does not account for any of the issues around patient vulnerability. So let's move on. My main concern, not as a pediatric radiologist, but as a medical consultant, so as a doctor, are we asking the question to screen as a screening question, or are we asking the question to diagnose? Okay, so these are two different ways of looking at a test, and the questioning is in effect a test. So there are different criteria for telling whether a screening question or a diagnostic question are appropriate and sound. If we look at the 10 criteria supported by the WHO for screening tests, we can run through these quickly. The condition should be an important health problem. That's actually up for debate, depending on how you feel about the potential adverse outcome to the fetus. Number 2, there should be a treatment for the condition. Well, there is. I mean, in this case, if we find out that the patient's pregnant, we can opt not to image. So that's the treatment in this situation. Number 3, facilities for diagnosis and treatment should be available. As I've said, our facilities aren't necessarily optimal. We're asking a patient in a way that does not account for their vulnerability. Number 4, there should be a latent stage of the disease. This is not really applicable. Number 5, there should be a test or examination for the condition. The test that we're trying to apply, the questioning, actually is not a good test because the patient may be untruthful or unknowing. Number 6, the test should be acceptable to the population. In fact, that's not always the case. We do get plenty of parents who are happy enough for the question to be asked, but a reasonable cohort who, on the other side, are not happy with their minor daughter being asked about the possibility of pregnancy. In fact, when I tried to go to our Youth Advisory Council to ask about this, they actually refused my request to speak to them because they didn't feel that it was a suitable topic for discussion with the teenage members of that council. Number 7, the natural history of the disease should be adequately understood. Okay, we can give it a tick on that one. We do understand the natural history of pregnancy. 8, there should be an agreed policy on whom to treat. It's not applicable. 9, the total cost of finding a case should be economically balanced in relation to medical expenditure as a whole. It's a free test, so you could actually give it a tick here, but I think it's more likely non-applicable. Number 10, case finding should be a continuous process. Okay, so we can say we've got that. We can be continuous about this questioning. But as you can see, we by no means meet all the criteria for this to be a good screening test. From the point of view of thinking about this as a diagnostic test, to be a good diagnostic test, a test needs to increase the probability of a condition being present in order to be worth doing. And in addition to that, the lower the pre-test probability of a condition being present, the stronger the test needs to be to result in a worthwhile change in that probability. We're going into this situation with a very low probability, we'll go through that in a minute, of the patient being pregnant. In addition, we're trying to apply a weak test because the patient's unlikely to answer appropriately. So we're going with a low pre-test probability, we're applying a weak test, and we're not going to help our post-test probability. Now, so in other words, the question's a bad test, whether you look at this as a screening test or you look at this as a diagnostic test. Unfortunately, the legislation doesn't account for this either, so it gives us no guidance about how good a test this question is. So what can we do? So looking back, when all this legislation was coming back in, being changed and reinterpreted, I went back to have a look at this to try and decide, who do we have to ask? So in a lot of departments, patients are starting, or, pediatric patients might be asked from the age of 12, for example. But why? Why is that? That's just, it seems like it's just habit. And actually, with menarche occurring as early as 8 years of age, especially in patients who are attending a pediatric hospital, potentially to see an endocrinologist because of early menarche, at what age should we be asking children about the possibility of them being pregnant? So existing guidance, and I've given you some references at the end of the presentation, it just really fails to offer a unified and practical approach for female pediatric population. So some guidance gives an age range of 12 to 55 years for questioning without provision of any supporting evidence. Another makes reference to females of reproductive capacity, but they don't mention any age limits. And as I've just said, if you've got menarche occurring as early as 8 years of age, then are we asking everybody from the age of 8? And I think then really you're talking about a lot of parental unhappiness and a very, very weak test. Particular problems, this is another reference, says particular problems may be experienced in obtaining this information from females under the age of 16 years. And yes, that's the case. We know that that's true. So if we go back to this part of our statutory instrument in Ireland and the wording that we have here, what I'm saying is, can we say that being under 15 means that pregnancy can be ruled out for obvious reasons. So is that an appropriate way to interpret this legislation for our patients? Okay, so here's my proposal, that in places with low pregnancy rates in the relevant age group, it is both prudent and appropriate to exclude many young patients from the process of establishment of pregnancy status for radiological procedures that utilize ionizing radiation, other than by assessment of age. And the age of the patient, we always know when they're coming to us. Okay, so I'm going to give you an example in practice. This is data from 2015 in Ireland. So the column, the first column there is less than 15 years of age, or less than or equal to. So that's the bracket that our Central Statistics Office offers us the data in. It doesn't break it down below that for numbers of pregnancies. So that's what I've grouped together. So live births were 42. Number of terminations, they were performed in the United Kingdom. Termination of pregnancy was not available in Ireland at the time. Number of pregnancies was 60. So in total, so in our population of over 180,000 in that age range, we had a live birth rate of 0.2 per thousand and a total pregnancy rate, including the terminations, of 0.3 per thousand during the year of 2015. As you can see in the 16 to 19-year-old age group, that does increase significantly. So you're talking about a very tiny number in the 15 and less, and a much bigger, more relevant number with a higher pretest probability in the 16 to 19-year-old age group. We repeated this in 2019 just to see what the data was showing and whether this was we could see any trends here, if pregnancy numbers had jumped or anything. So again, in our less than 15-year-old age group, very small, so 0.2 per thousand, our rates had actually dropped for both live births and terminations. And again, you can see, even though it had dropped in the 16 to 19-year-old age group, it is much higher, significantly higher than in the younger group. So what's the context of these numbers? So we're saying 0.2 per thousand. In adult radiology departments, it is often the case that if a female comes in for an imaging procedure using ionizing radiation and they tell the radiographer that they are using a method of contraception, that's accepted as a reason why they cannot be pregnant. Okay, so in the law, unless it can be excluded for obvious reasons, an obvious reason is accepted to be that they're on contraception. But let's have a look at the failure rates. So we are accepting failure rates of 2 in 1,000, 3 in 1,000, up to 5 in 1,000 for tubal ligation, but accepting that these patients can't be pregnant at the same time. These are an order of magnitude higher than our patient's pregnancy rate. So this I'm going to call the Dublin Proposal in my best Eurovision manner. I'm saying girls aged 14 years and younger will be excluded from obligatory pregnancy status questioning for the purposes of radiological examination, just as is the case for adult women on methods of contraception that have rates of failure significantly higher. Okay, we'll still display our statutory notices about the risk of radiation, and we'll continuously monitor our pregnancy rates in Ireland in this group to make sure that it still applies. I'm lucky, after many years of working, we've now managed to get our institution, Children's Health Ireland, to accept this proposal, and it's currently in the phase of implementation. So these are the references, just a few references that are based in Ireland and the European Commission. I think they do need to be updated with some specific paediatric reference, hopefully with the Dublin Proposal, but I'm very happy to take questions and comments and answer them if I can. Thank you.
Thank you very much, Aisling. Hopefully everybody can hear me and see me now. Okay.
We can, yeah.
Great, thanks for that. Thanks, Aisling. It was a really fascinating talk. Now, we really appreciate you bringing your clinical expertise to talk at this dosimetry meeting. There's a couple of comments and questions in the Q&A if you could take them for us.
Sure.
So there's an interesting comment about we've had some success with asking when parents are not within hearing range. When a young pregnant patient is asked when parents can't hear the question, they have answered with a yes. Do you find that in your clinic you would have the same or the arrangements for asking when parents are within hearing range?
It's a difficult one because it's actually hard to separate your pediatric patient from their parent or guardian, because the parent or guardian should be with them during their time in the hospital. So it can be in practice difficult to do that. And if you're talking about just asking them while you walk slightly ahead of the parent, you know, I think in order to do that, you would have to have a departmental policy, a separate area for questioning, you know, talk to the parents and say, I need to talk to your child alone. There are a lot of practical issues there. It certainly, in some cases, may be possible to do that. What I would say is don't forget that if we base this on data, we know that the rate of pregnancy in these patients is very, very tiny. Can I tell you that there will never be a case that will slip through, that there will not be ever one of those very few patients who are pregnant in that age range in Ireland who come to our hospital during the 10 months of pregnancy and need a relevant examination? Of course, that's possible that all of those things will line up and one of those patients will come and we won't ask them. But at the same time, we don't have an issue with it when it's in an adult hospital. You're talking to a woman who's on contraception and we accept that there are failure rates. So what I'm saying is not that this will never allow a patient who is pregnant to be imaged, but that it is appropriate not to ask because the likelihood of that happening is so small.
That's great. Thanks, Aisling. We had another comment, which is just maybe more about adult hospitals. Well, I'll pose it to you anyway. Is the question about contraception asked to all adult females prior to asking about their pregnancy status?
I think that depends on the hospital and the department and what their local procedures are. You might be able to answer that better than I would because you're based in an adult hospital. Yeah,
so again, so it depends probably on hospital policy, and Geraldine's covering some of that actually in the next talk, so we might be able to tease that out afterwards as well. But on your talk as well, there's comments that it's really a very interesting proposal. Have you looked at the possibility of other countries and what their rates are under 14, and just that it's a really good presentation? So maybe what are the plans for you know, have you any plans to bring it to a national level or look at it in other countries?
Yeah, so just starting with Ireland, because our population is quite small, our data is for the whole country, for the Republic of Ireland. So it will be applicable in Children's Health Ireland. Once we have brought the protocol into action within our 3 hospitals, then we will make it available for other pediatric centres that are imaging children around the country. And I think our CEO is interested in making a recommendation to other CEOs to consider it. So that's for Ireland. From the point of view of other countries, it's interesting. With bigger populations, it may actually be necessary to look at different areas of different countries. So certainly I had a look at some data for the United States. Pregnancy rates in this age group can actually vary quite a lot depending on which state you look at in the US, or even which city within large states you look at, or if it's a rural area versus a built up area. So I'd be very happy, you know, if people have data for their countries to look at it with them and see in Europe how applicable this might be, and whether we need to drill down into specifics of areas, regions, you know, cities versus other areas. I do know in the United Kingdom, their pregnancy rates are higher. So okay. I think wherever someone is considering this, you do have to be very careful to look at those pregnancy rates and make sure that you're not putting patients at risk. Our plan now is to publish it. So our plan is to publish this as a journal article.
That was great. That was just my next question. Is he going to be able to publish it?
Yeah.
Aisling, that's absolutely fantastic. You're getting, you know, great feedback on the chat as well, and really appreciative of you joining us today.
Thank you.
And thanks for your time.
Thanks very much.
Thanks to Dr. Aisling Snow again. So I'd like to move on now to our next speaker, Dr. Geraldine OReilly. I'll invite Geraldine to join and turn on her camera if she can. So Dr. OReilly is the Chief Physicist and Head of Medical Physics and Bioengineering in St. James's Hospital. In addition to her hospital role, Geraldine has been very actively involved in the development of radiation safety legislation and standards for many years, and she's a member of the Article 31 group of experts that advises the European Commission. She lectures on a number of academic programmes, and we are really very grateful to Dr. OReilly for her time today in joining us at the EURADOS Winter School. I'm going to ask Geraldine now to take the stage, and she's going to present to us on radiation protection of the fetus during diagnostic radiology in an adult hospital. Thanks, Geraldine.
Okay, thanks very much, Una, for the introduction. Like also just to thank the organisers for inviting me to speak this afternoon on this topic. And I think we can see from the presentations that we've had yesterday and today and the attendance that it really is a topic which generates a lot of interest. And I think anybody who has any sort of role working with ionising radiation will confirm that this is one that we get asked about all of the time. When we think about the considerations that apply to the radiation protection of women who are pregnant or who might be pregnant or trying to get pregnant, we need to think about it from a number of different perspectives. First of all, we looked to the radiobiology, and we had two great presentations yesterday which gave us a little bit of insight into the risks. So we need to understand that so that it can inform our approach. We also need to look at the legal framework within which we're working and see what are the requirements and the provisions that are contained with our European and national legislation. I think the next thing we need to think about is communication. How are we going to communicate between healthcare professionals, but then most importantly, how are we going to communicate to our patients? And what do we understand enough about the risks that pertain to communicate knowledgeably to the patients? And have we sort of promoted education of patients and the general public to a level that they're well positioned to take the information that we give them and able to make decisions based on that information? I think the last thing we need to think about is that this is a really personal and individual topic. And I think for all of us, our perception and acceptance of risk is very variable depending on whether the risk applies to us and at what time it applies to us. And I think for somebody who is pregnant or trying to get pregnant or might be pregnant, their willingness to accept even small risks can be very different to what it might be at other times in their lives. So just to put the context, I'm working in a diagnostic hospital. I think we'll hear later from colleagues in other types of hospitals. So we know that for well-planned diagnostic medical exposures, the radiation dose to the embryo or fetus, it shouldn't pose a risk of deterministic effects. So we won't have to worry about fetal death, malformation, growth retardation, or impairment of mental development for almost everything that we do in an adult hospital if the exam is planned and goes according to plan. But what we do know is that there is a risk, even if it's a low risk, associated with diagnostic procedures. And the risk is of the order for many of the procedures that we carry out where the fetal dose would be up to 1 milligray. It's less than 1 in 10,000. As we go to higher dose examinations, of course, that risk is going to increase. So we do have legislative provisions to protect the patient and the unborn child, and we also have a number of guidance documents available, but we don't have dose limits for our patients. So if we look at the provisions of the European Directive, we see two key provisions within that, the director. The referrer or the practitioner, for relevant exams, they must ask whether the individual could be pregnant. If pregnancy can't be ruled out, then they need to look to the justification and particularly the urgency and consider whether there's alternative exams that involve less or no ionising radiation or whether the exam can be deferred to a point at which pregnancy status is clearer. If the exam is to go ahead and the individual is pregnant or might be pregnant, then we have to apply what optimisation measures we can to that exposure. So we've lots of guidance documents available to us, and I've shown some of those on this slide. And I think looking at the various guidance documents, some of which are quite old, and that was mentioned yesterday, we probably have a need to update some of the guidance. While I think looking at them, you could say that there's broad consensus in terms of the underlying radiobiology and the associated risk. But what we don't find in them really is what are the practical measures that we will follow in our hospital. So how are we going to deal with this on a day-to-day basis? And there are differences in how we apply some of the practical tools that we have, such as the 10 and 28-day rule. So there's a need for something that's very clear and that we can take into our healthcare institutions, which will guide us in to how we deal with this issue. So what are the issues? Well, we first of all need to know what exams are we talking about. So the European legislation says for relevant exams. So we need to identify what those exams are. We need to figure out what age groups we're going to apply these provisions to. We need to figure out when are we going to ask about pregnancy status and who's going to ask that question. When we have a response from the patient, how do we capture that, and how do we make sure that that response it forms part of their record, and how we manage them going forward? How do we deal with patients where we don't know the status? How do we deal with patients who are on long-term contraceptives? How are we going to deal with our urgent or emergency exams? And do pregnancy tests have any role in this? And if we are going ahead with an examination where the patient is or might be pregnant, how do we do that safely? So some years ago, there was a group that came together in Ireland just to try and take the legislative provisions and the recommendations in the various guidance documents and develop something that would be common across healthcare institutions, because it was very confusing for our patients as they went from hospital to hospital, and we all did something just a little bit different. It was also very confusing for our medical staff, who would tend to move between the various hospitals, that our approach could vary depending on where you were working. So in developing this policy, we had great input from all of the relevant professions, which really, I think, broadened the perspective and ensured that all that stakeholders, as many of them as possible, were included. So we had radiologists, radiographers, physicists, regulators, GPs, and lawyers. So just to start, within that policy, we tried to answer what are the exams and age groups that we think it's relevant to ask the pregnancy question. So the policy states that we will ask that question for any radiographic, fluoroscopy or CT examination where there's going to be a radiation between the diaphragm and symphysis pubis. For any radionuclide imaging procedure, so that's all nuclear med and PET, and between the age range as a guide was given as 12 to 55. So for those exams, at a minimum, we're going to try and establish pregnancy status. Just to get a sense of what that might look like in an adult teaching hospital. So I'm working in a 900-bed hospital. We do over 120,000 X-ray and nuclear medicine PET exams per year. And if you look down the list of the various modalities, you can see the numbers of exams that we would do every year. If you think about what percentage of those will fall within the scope of the policy, so that's which exams, how many exams will we have for female patients in the age range of 12 to 55, and where the X-ray exam will irradiate between the diaphragm and symphysis pubis, and all our radionuclide imaging procedures. So you can see the percentage that fall within the scope of this policy in our hospital, and the numbers will vary depending on the examinations that are carried out with that modality, depending on the typical age profile of the patients that present for those examinations. And then some modalities also will have a difference between gender in terms of the patients that present. If we drill down a little bit further into it and just look at our CT exams and our radiographic exams and look and see how many exams are we going to have to ask the pregnancy question for. So you can see that it's about 5,000 exams, and that's without taking the fluoro and the radionuclide imaging exams into account. It's also interesting just to see how does it break down across the age bands, because as we heard in the previous presentation, the age range is somewhat arbitrary. So it's sort of interesting to see if you were to use a higher, starting at a higher age and finishing at a lower age, what number of exams would you have, and how do they distribute across across the various age groups. So that's the sort of scale of the issue that we're going to have to deal with and try and find something that works. So what has to be done? Well, for all of the exams that fall within the scope of the policy, the referrer and/or the practitioner has to ask the patient about pregnancy status and asks about the date of the last menstrual period. They have to make sure that the exam is justified, and the practitioner should be provided with all relevant information as part of the examination request so that they can properly determine the appropriate exam and justify it. For high dose exams involving greater than 10 milligray, then we're going to apply the 10-day rule. So according to this policy, some subset of those exams for which we ask the pregnancy question, we will apply the 10-day rule. Now, the one thing that we have to do for all of those patients that fall within the scope is we have to ask the pregnancy question. So that sounds straightforward enough, but it's not. Even for an adult population, it's not necessarily that straightforward. For our outpatient procedures, we can have long waiting times between referrals and the exam. So asking the pregnancy question at the time of the referral, it may no longer be relevant in terms of the answer that you got. The patient mightn't be certain of the pregnancy status, so you won't necessarily get an accurate answer. We can have communication problems, such as those that arise with language, with deaf patients, and there's also cultural and social barriers to asking these questions with some groups. We also need to think about what do we do with our anaesthetized patients. So have we established pregnancy status before they were anaesthetized? What happens for the unconscious or emergency patient where we don't have the opportunity to ask that question? We know how difficult it is to deal with this issue in children, as we heard from my colleague in CHI. What about the patients who are on long-term contraceptives, which we know are not 100% reliable, so we need to think about how we deal with that patient group. Sometimes a urine pregnancy test can be used, but we just advise caution in using that in order to essentially bypass the justification process. So we don't routinely use it. And the reason that we don't use it is that if you look at the sensitivity of those tests and compare it to the range of HCG in early pregnancy, you find that the sensitivity is very often is going to be inadequate in very early pregnancy, and even in weeks 4 and 5, it will miss pregnancy. So a negative pregnancy test is not actually going to tell you that the patient is not pregnant in those circumstances. So it can be a useful source of additional information for patients who have irregular periods or in certain circumstances, but it shouldn't replace proper and direct inquiry. So we use the 10 and 28-day rules, and the 10-day rule is where we carry out examinations involving ionizing radiation only in the first 10 days of the menstrual cycle. And it's believed that during that time, for somebody with a 28-day cycle, the patient shouldn't or couldn't possibly be pregnant. The 28-day rule, or the missed period rule, is where women of childbearing age, they can undergo medical exposures during the first 4 weeks following the date of the last menstrual period. And then if the period is overdue and the patient cannot be certain that she's not pregnant, then you consider postponing the examination. So within our policy, we apply the 10-day rule for our higher dose exams, and then the 28-day rule can be applied for lower dose examinations. Again, sounds straightforward, but it's not. So there are situations where the 10-day rule can't be easily applied. So, for instance, in adolescence, which are very irregular periods, in perimenopausal females, it's obviously wouldn't be appropriate to apply it for patients who've had a previous hysterectomy. So we do allow our referring clinicians the option of waiving the 10-day rule, but they will still ask the patient about pregnancy status and confirm the answer in writing at the time of the exam. So when the referrer waives the use of the 10-day rule, they're not necessarily confirming that the patient is not pregnant, but they're telling the practitioner that the exam is urgent and it should be carried out irrespective of pregnancy status. Or they're telling the practitioner that the 10-day rule is impossible to apply. Or they could be telling the practitioner that pregnancy is not possible for a variety of reasons. So what's important is that each facility should understand the list of procedures for which the 10-day rule will be applied. And I've given some examples here. So depending on the facility, this list may be longer and may include some examinations. It very much depends on your technology, your exam protocols, and so on, which exams you consider appropriate to include in the 10-day rule. So what happens when the patient turns up for an examination for which the 10-day rule normally applies? Well, they'll be asked about their pregnancy status, they'll be asked for the date of the last menstrual period, and the radiographer will explain why this question is being asked. So one possible scenario is the patient advises that she's not pregnant, that she's within the first 10 days of her last menstrual period, so the procedure may go ahead. Next scenario, the patient has indicated that she's not pregnant, she's not within the first 10 days of the last menstrual period, but the referring doctor has waived the 10-day rule and documented why they are doing that, so the procedure may go ahead. Then we have scenario 3, where pregnancy can't be ruled out. So at that point, the practitioner will look to see is there an alternative imaging modality available. If there is not, they'll look to see is the exam urgent and justified, and if it is, the procedure may go ahead. And if it's not, then the patient will be rescheduled till a later time. Now, for all of these examinations, we're going to keep a record of the interaction with the patient. So all of the exams that we're talking about, they all fall within the scope of our policy. So we're going to be asking the pregnancy question for those exams that I indicated. And we're going to capture the patient's response and document it. If the patient is outside the first 10 days and the exam is one that we would normally apply the 10-day rule, then we will either reschedule the exam, or if it's going ahead, then we'll document why we're not following the 10-day rule. And the patient and radiographer will sign the form, and it's scanned into the patient record for that exam. If a patient is pregnant or might be pregnant and the exam is going ahead, and it's an exam that we consider we would have usually applied the 10-day rule, then we will retain a record to indicate that the justification has been looked at again and confirmed that the examination should go ahead. And this will again be signed and scanned into the patient record. So, should all work well, but a couple of case studies might just illustrate some of the challenges that we encounter on a day-to-day basis. So an example that happened some years ago, a 45-year-old lady referred for CT urogram. This exam is one in which the fetal dose is likely to exceed 10 milligray, so the 10-day rule would usually be applied. So a letter was sent to the patient with an appointment date, advising that if that date fell outside of the first 10 days of her cycle, then she should ring the hospital and schedule an alternative date. Now, if you just think about that, you have a 1 in 3 chance, if you give somebody a fixed date, you have a 1 in 3 chance that you're falling within the 10-day window. And patients tend to be anxious about getting scans for which they've been referred, and particularly because we can have long waiting lists. So there are already some things that might suggest that this mightn't work as intended. So on the day of the exam, the patient presented, and it was discovered that she was outside her 10 days, but she confirmed that she wasn't pregnant and she signed to that effect. And in fact, the patient believed she was in early menopause. Scan went ahead without incident, but some months later, during a follow-up ultrasound, pregnancy was noted, and the fetus at that stage was 18 weeks. So it was estimated that the patient would have been between 4 and 5 weeks at the time of the CT, and the fetal dose at that time would have been estimated to be 38 milligray. So this fell within the category of notifiable incidents and had to be reported to the regulator. And the key question that the regulator is going to ask in these situations is, was your process sufficiently robust? Could this have been avoided? Could you have done something differently? So the regulator asked, having looked at what had happened and talked to all involved, the regulator in fact asked that the existing policy be revised and asked that it be changed so that the communication processes with patients in advance of the exposure were improved. The reasons for excluding pregnancy were to be documented, as well as an agreed definition of menopause that would be used within radiology, but also for the referrers. And other actions that had to follow from that incident was just to communicate in general to referrers about their responsibilities in the referral process and communicating to the patient why it's important that they're not pregnant at the time of an exam. And the changes in documentation and the shared learning was brought to all relevant staff. Another case study where we had a 33-year-old female who'd been referred for a CT abdomen pelvis, and a letter was sent to them asking them to contact the department on the first day of their next period, and they'd be given an appointment within the following 10 days. So that happened, and the appointment was scheduled. On attendance, the patient confirmed that she wasn't pregnant and advised that the date of the L&P was 5 days previously and signed a form to that effect. So the exam was completed, the report issued, but a couple of days later the patient phoned to say that she'd discovered she was pregnant and she was very anxious. And what had happened was that the patient had mistaken a bleed in early pregnancy for a period. So the dose to the fetus was estimated to have been 11 milligray, and the incident was reported to the regulator and an investigation report requested. And again, the key question from the regulator was this process sufficiently robust? Could you have done something differently? So in investigating the incident and follow-up, it was found that the 10-day rule had been applied appropriately. The patient, in fact, confirmed that staff had asked her about pregnancy status and had explained why they were asking and the associated risks, but at the time she'd been very confident that she couldn't have been pregnant. And the communication and consent was documented in her record. So the regulator was satisfied that protocols had been robust and no further actions were required. Now, obviously, there was a lot of communication with the patient to make sure that she had all the information she needed and that she was provided with reassurance. One of the things maybe just to highlight about these two quite different incidents happened in two different organisations. You can see the slightly different approach in the two organisations was in both occasions the patient confirmed and believed that they couldn't possibly be pregnant. So it's just an important thing to bear in mind, because we do place quite a bit of reliance in certain approaches on what the patient tells us, but the patient doesn't necessarily always know. In this country, as in many other jurisdictions, as we heard yesterday, if there's an exposure where none intended and there's an inadvertent dose to the fetus, it's notifiable. So in the case of those two incidents, they were both notifiable to the regulator. One of the things we need to think about and plan is, like, what do we tell patients after an inadvertent exposure? So within healthcare, we have an open disclosure policy. So patients have to be told when things go wrong. And the literature would suggest that, in fact, most patients want to be told the truth. One of the things that I think is really important is that in managing radiation incidents, you work within your existing risk management frameworks, because within that there will be good tools for both reporting incidents and follow-up and investigation and guidance on the communication processes between the healthcare professional and the patient. So while it might be the physicist that talks to the patient, much more often we would have the clinician who knows the patient speaking to the patient after the exposure, but they will have been provided with information on dose in a format that they can understand and communicate appropriately to the patient. One of the things we have to figure out is what will we do when we do have to scan pregnant patients, because although it's not that often, it certainly does happen. So we've seen that we will document the justification, and then we look at what our options are to reduce the dose without compromising the diagnostic quality. So it'll vary depending on the modality, but there are some techniques that we can apply. And so each organisation really needs to think about these in advance and have a plan for what you will change if you have the opportunity to change anything to minimise the fetal dose when you do have to scan a pregnant patient. In radiation protection, justification and optimization, they're fundamental in everything that we do in radiation protection. So we spend an awful lot of time in minimizing risk and even reducing very low risks. But in a way, some of what we do, while we will continue to do it, it can contribute to a heightened perception of the hazard. And yet, when an incident occurs, often our message is one of reassurance that the actual risk is very low. And it really comes back to this challenge of managing individual and collective risk. So I think in terms of our communication strategies, whether it's before an exam, after an exam, or just in general, we really need a range of approaches, and how we present risks strongly influence interpretation. So I think it was mentioned in one of the presentations yesterday that this is an area where we really need to improve our communication strategies as healthcare professionals, and it's an area that we probably have neglected. But I would refer to the fantastic work that's been done by the WHO and the guidance documents that they have produced, which really are very helpful in trying to guide us in terms of communication. But I think in general, I think we would have to acknowledge that within healthcare, we probably have some way to go to improve this. So just to summarise, European and our own national legislation provide us with a framework for medical exposures, and explicit within that framework are the provisions that will protect the fetus. So in diagnostic radiology, what we will be trying to work towards is minimising the risk of stochastic effects, and in well-planned exposures we shouldn't see deterministic effects. What we need to take account of is the individual perception of risk, and it's influenced by factors other than the absolute magnitude of hazard, and we have to consider this and take this into account. So the perceived risk is very important. When we're talking about risk, we should reflect on uncertainty, but also our communication should be appropriate to the level of risk, and most importantly, it should take into account the individual. I think in this area, it's really important that we increase awareness among all of us, our patients, healthcare professionals, and general public about this area, so that we're all better positioned and enabled to have the conversations that we have to have. And I think appropriate and timely communication is central to managing this issue. So we need to think about our communication strategies when they occur and how we communicate information. And it really does need input from all of the relevant stakeholders in order to come to a successful strategy. Okay, thank you. Happy to take any questions if there are.
Thank you so much, Geraldine. That was fantastic. I think, again, the Winter School really appreciates getting the perspective of the medical physics expert in this area, so we're very grateful for that. There's one or two questions. I might just firstly come back to the question that came up earlier after Aisling Snow's talk. Is the question about contraception asked to all adult females? Sorry, it just popped away. Is it asked to all adult females prior to asking about their pregnancy status? Or is it something that maybe if the question is asked first and this comes up during the discussion?
Yeah. So no, it wouldn't be asked first. So the strategy, so we have a legal requirement to ask about pregnancy, and it follows on from then. So, you know, for particular exams, we will use the 10 and 28 day rule. If you get to a situation where the referring clinician is looking to waive the 10-day rule, reliable forms of contraception could be part of the rationale for that. So it wouldn't be the first question that we ask.
That's great, thank you. There's another interesting question as well about the difficulties with the 10-day rule. So with a large number of service users falling into the females of reproductive capacity, do you find that there are difficulties finding suitable appointment slots to fit around multiple 10-day rules?
Yeah, I mean, I think we're in this hospital, we're very lucky in that we've got a fantastic admin and radiographic staff, and they're very used to using the 10-day rule. So it's embedded into our ordering system. So certainly for our inpatient referrals, the questions will come up. So the referring doctor is prompted to give us the information that we need. And so it's not a trivial task to schedule the relevant patients into that 10-day window. But it is something that has been embedded in the process for many years. So it's something that they're used to. But it can be difficult if you're introducing it for the first time.
And feedback from Dr. Aisling Snow, and a question where she was asking, do you see a scenario where you might also apply the pregnancy rate assessment to your upper age range, which is currently at 55 years?
Yeah, I mean, I think I was interested in Ashley, very interested in Ashleen's presentation, and I think it warrants some attention. I think the idea of the sort of risk-based approach and taking account of the professional, the individual, is very important. So at the moment we use the 12 to 55, which is in the national policy. I think when we come to revise that either at a national level or locally, we can consider that, and it has posed some challenges for us, including that group, and again, it's perhaps the age range should be different.
Okay, thanks. I know we're just running short of time. There's one more question. If you have time to think about it, we might bring it up again at the round table because it's interesting. How are you dealing with the transgender patient, specifically if they're in the process of transferring from females to become man? Do you have this information in their referral, and considering their privacy? Yeah,
that's a really interesting question, and I'm afraid I don't have the answer for it, but I can tell you that it has occurred in this hospital. And when it did occur, it was a patient who was asked, because the radiographer believed that there was a legal requirement, because the patient presented as male but had been born as female. So we had some discussion, and I have to say, I would take the view, which may not comply completely with the regulation and may not be a popular one, but I think you have to look at how you deal with your patient as a whole. So rather than focusing on something that, as Aisling pointed out, for the younger population is probably a lowish risk in terms of pregnancy, but when you look at the upset that caused to the patient, that we had that situation with, you'd have to wonder at the damage that was done to the relationship between the healthcare professional and the patient, and was the added value of eliminating what was probably a small risk of the patient being pregnant and a very small stochastic risk anyway. I would really wonder at the utility of applying that. But I think we need a discussion about that. It's a really interesting question, but we need input from a wide range of stakeholders, including our patient population, on that one.
Yeah, thank you. I totally agree. It's a really interesting and very topical question. So, Geraldine, I'd like to thank you once again very much for your time. And I think we'll see you later at the roundtable discussion. Thank you.
Thanks, Una.
So I'd like to invite to the stage now Professor Frederick Ammann, if we have Professor Ammann available backstage, hopefully. And thanks everyone. And anyway, during the winter school, for bearing with us with any small technical difficulties. This is a feature of life now. But as been said before, hopefully it's opened up the winter school for more of you to join online. So as we're just waiting for Professor Ammann to connect, I can start to introduce him. And Professor Frederick Ammann, we're delighted. That's great. I can see your slides now. And your camera is joining. So we will have Professor Frederick Ammann from Leuven in Belgium. Professor Ammann is an obstetrician gynecologist, and he has specialist training in gynecologic oncology. And as such, he is extremely active in research on cancer in pregnancy. And with all of his work, he aims to bring research closer to the clinic. So we're really very delighted to have Professor Ammann join us today to speak to us. And I can now invite him to present to us on cancer treatment during pregnancy. So I'm going to turn off my camera. I can see your slides, but we can't hear you at the moment. So I'll just turn off my camera and see if we can get some audio. Okay, so if we can just bear with Professor Ammann for a moment. He did have to leave. He will rejoin. He's just leaving and rejoining to set up the mic. So as before, any questions can just go into the Q&A. As they're being answered, they're being moved off to the answered section, which is convenient. So any of our speakers will. Okay, so Professor Ammann, we can see your slides. I just can't hear you. So I don't know if anybody else can hear. His microphone is on and he can see the slides, but I can't hear him.
Do you hear me now? Okay. Okay, Una, do you think I can start? Okay. Apologies for the technical problems. We tested the system half an hour ago. It worked perfectly. Then at the big moment, there are some problems. But I also want to thank the organization for allowing me to share with you our experience on cancer treatment during pregnancy. Basically, I have 3 take-home messages. I want to show you that chemotherapy during pregnancy is possible, that within all the cancer types that we face, cervical cancer is the most challenging, and that an interdisciplinary approach in referral centers is actually mandatory and the best guarantee to treat our patients appropriately. This is basically the agenda. I will go through it. I will only briefly touch radiotherapy, but we will start with a case study illustrating what we are faced with in the clinic. This is a patient from April last year. It was actually a challenging situation. Important to understand is, or to know, is that she had actually a history of a preterm twin delivery at 26 weeks in her first pregnancy. And now she presented with a stage 1B2 cervical cancer of the squamous type at 14 weeks gestational age. And again, this was a twin and then a monochorial twin. So the obstetric twin is already an issue. Her history is an issue. And now she has this cervical cancer. Here you see the in speculo examination. We see here the fetus on MRI, and we see here the cancer actually in close proximity to the fetus. One of the first things that we did is to, we could exclude distant metastatic disease. We do surgery. This is an extraperitoneal lymphadenectomy. That means we do not enter the peritoneal cavity, but we remain outside of it. And we do, this is a view on the left side wall. You see the blood vessels, so where we remove lymph nodes in order to define whether these are involved or not, and to identify high-risk disease. Luckily, lymph nodes were negative. We started with chemotherapy. Here you see the cancer actually after the chemotherapy, which is clearly reduced, or there was sensitive to the chemotherapy. She basically received 5 cycles of chemo. We did do a cesarean section at nearly 35 weeks of pregnancy. So basically, we had near-term babies. We could spare a difficult pregnancy in a challenging obstetric situation. So that's what we could mean to this patient with all the experience we have. And now in the next, I will briefly further go into depth into this issue. Regarding the epidemiology, it depends a bit on the registry, which cancer is in fact the most common. For example, this is at the left, Hannah Stensheim's Scandinavian study, and there all melanomas are also registered. And here you see that in fact melanoma is the most common cancer. In overall, melanoma is not so well registered, and then you see that breast cancer is actually most commonly present in during pregnancy, and this is also the cancer that we most of the time see in these young women of reproductive age. And we do estimate that about 1 in 2,500 to 5,000 pregnancies in Europe on a yearly basis are confronted with this problem. From our registry, we also see this is the breakdown per stage, per different cancer type, that for different cancers, we have different stages. For example, for breast cancer, it is most stage 1, stage 2, but then for digestive colon cancers, it is actually frequently an advanced stage. So overall, there is maybe a slight delay due to the pregnancy signs that may mimic actually any cancer. This is a study from our group from 2 years ago, where we see actually an evolution over the years. So this is less before 2005, this is between 2005 and 2009, and this is after 2010. And what we see every 5 calendar years is in fact 10% more patients are treated during pregnancy, 31% gets more patients received chemotherapy during pregnancy, 4% more live births, 7% fewer preterm births, 9% fewer iatrogenic preterm live births, 9% fewer neonatal intensive care unit admissions, but there's a price to pay because there was 16% more small for gestational age. So it gives you a flavor of we are getting more experience, we are treating more and saving actually more children from this situation. And we do believe that the incidence will further increase because of the non-invasive prenatal testing. Many of you, and certainly women among the audience, will know these tests. It is a test done to detect fetal anomalies in pregnant women. But what we know is that, well, we will be able to identify this fetal DNA, but there is also basically maternal DNA that you can check. And basically in 2015, we were the first to report actually to diagnose maternal cancer based on a NIPT test. And since NIPT is more and more used, we now already see in the clinic actually more pregnant women who are asymptomatic, who come for a test for their baby, and we diagnose actually cancer in these women. And we are confident that this will further increase in numbers. This is an example of actually one of the first cases. Here we see the NIPT. These are the copy number alterations, higher and lower. And basically, a geneticist will say, well, this has nothing to do with the fetus. This is a signature of cancer. So we did do a whole body MRI, and indeed, we did see actually a Hodgkin lymphoma. And further testing proved that the DNA in the mother was the same, or in the blood used for the NIPT was the same as in the tumor. So we are confident that a tumor was responsible for this abnormal NIPT. So it will further increase in the future. In the clinic, it is important to know that pregnancy may mimic cancer symptoms. And these are 2 examples we see here of breast cancer. And here at the left, I hope you see my cursor, you can already appreciate that the left breast is slightly red. So this is inflammatory breast cancer. And you can also appreciate already an enlarged lymph node. So that's the gestational breast that basically did not allow early detection of a cancer. Also here, actually by view, actually this breast looks normal, but if you do an MRI, you see that 2/3 of the breast is basically replaced by cancer. Also here, the pregnancy alterations delayed the diagnosis. So it's important for clinicians to know this and to act appropriately when patients complain. The previous speaker already covered this perfectly. We know that we can apply radiation imaging where needed, because these patients need to be staged as control patients, as other patients, in order to have no deterministic or stochastic effects. In fact, we try to apply as little radiation as possible and to use sonography and magnetic resonance imaging in this population. And we will only do this radiation when it's really necessary and changing actually the clinical approach. We have we use a whole body diffusion weighted MRI in Leuven, where we had actually the experience that it works very well, and that with one examination you can stage the whole body. This is actually conventional MRI. This is a patient, you can appreciate the fetus here with colon cancer, and on conventional MRI at A, B, and C, we could not detect liver metastasis. However, unfortunately, in the MRI, the whole body MRI, we could identify this liver metastasis. So this is the way, if you have this technique available in your center, how we want to stage, or how we stage our patients. Also for the audience who is familiar with this radiation problem, also even sentinel node is possible during pregnancy. In breast cancer, we use 18.5 millibecquerel, and this is possible because, in fact, the fetal dose is actually quite low and much lower than the threshold dose. This is because, in fact, we use quite low dosage, but also because 90% of the technetium is captured in the lymph nodes. For vulvar cancers, which you maybe would not expect that it would be possible because it's much closer to the fetus, even there it seems to be possible. We also use patent blue sometimes for this sentinel. However, this can provoke an anaphylactic reaction, and especially during pregnancy, this is difficult to treat, so we try to not to use it. But there's also an alternative. There are some reports, only no large studies, where we use indocyanine green for sentinel node, and in this case for cervical cancer. So it's only an immunofluorescence. There is no radioactivity involved here. So that might be a new future direction in this case. What about surgery during pregnancy? Basically, we can be very short. We have a lot of experience, or at least anesthesiologists have a lot of experience to operate or to put asleep pregnant women because of many non-oncological reasons. One of the important messages is that if you take care for the mother, then you take care for the baby. So provide adequate oxygen. And for example, in pregnant patients that are more than 20 weeks, we put the patients in the left lateral tilt position, making sure that actually the preload to the heart is actually sufficient, and that actually there is no hypovolemia, no blood pressure that is too low that may impair actually fetal health. There are many recommendations on that. There are no randomized trials, but for example, do we need tocolytic drugs in this population? Well, especially in gynecological cancers, when there is uterine manipulation, that might trigger some contractions, and there we use these drugs. Of course, pregnant patients are at risk for thrombosis, also cancer patients, so also this thrombosis prophylaxis is in fact indicated in this pregnant population. I will only have one slide on radiotherapy because it has already or some parts have been covered by previous speakers. This is just one example of how we irradiate during pregnancy. We basically know we can irradiate, but that depends on the duration of the pregnancy and depends on the organ that needs to be irradiated. So basically upper parts of the body early in pregnancy or early second trimester of pregnancy can be irradiated. This is our physicist who calculated actually that for this patient with breast cancer, that at the end of the first trimester, beginning of the second trimester could be irradiated. And here we see that the fetus is protected by a LED screen. This patient received this radiotherapy and actually with a good maternal, but also a good fetal outcome. However, I will mainly, if my slide continues, focus on chemotherapy, and that is quite interesting. There are some general rules of safe application of chemotherapy during pregnancy. We also made a big step forward because of the fetal safety that will come afterwards. So with this fetal safety, we know we can apply it, but there are certain rules. And rule 1 is here, we have to maintain the dose intensity. It's not because the patient is pregnant that we have to use another dose. We have also to use the standardized protocols because they are associated with the best response, with the best outcome. So we should not give other chemotherapy than the standard. The weight of the patient changes every day, basically. So every 3 weeks when chemotherapy is given, we have to recalculate the dosage, which is not done in non-pregnant women. And it's also not because of the patient is pregnant that we should increase the dose. So maintain the dose, the same cytotoxic drugs and the same combination. And we recommend to discontinue chemotherapy at 35 to 37 weeks because we don't want a mother to deliver when red blood cells, platelets, white blood cells are actually low due to the chemotherapy. So these are some recommendations that we use. Important to know, and this is a paper just from last week from our group, where we investigated to what extent the increase in maternal serum during pregnancy leads to chemodilution. And that is indeed the case. This is the 0. So we did do all the calculations during pregnancy, but actually lower when compared to controls. In blue, the area under the curve. In orange, the C max for 4 different drugs. So in all investigated drugs, we see that actually there is a lower dosage, lower blood levels when compared to non-pregnant women. So there is a chemodilution. However, the effect also differs according to the drug, and the dilution is the most important for paclitaxel. Of course, this questions, is this chemotherapy as effective as in non-pregnant women? I will show you, illustrate this with 1 case and 2 reports. This is a colleague who asked opinion from Venezuela. This is stage 2 cervical cancer. Again, the in speculo examination with a cervix which is completely replaced by cancer. On the MRI, we see the fetus, and here we see the cancer, and we see here that the cancer is actually already growing outside the cervix. This is actually at the start of chemotherapy, and you see that actually with chemotherapy that the cancer is really shrinking. This patient received then cesarean section and radiotherapy, and this is basically the end result. So despite the chemodilution, chemotherapy is effective. If we look to larger series, together with the German breast group, we look for breast cancer, and we see that the disease-free survival and overall survival were not different in this population. Also, in cervical cancer from the INSIP group, we see that actually there were no important differences between controls and study patients. But nevertheless, we have to say that for all cancers, we basically need more data to really prove that this is the case. But until now, until the data we have now, we can we can continue where we do believe that this is still safe for the mother. Important is the long-term pediatric outcomes when we receive chemotherapy. And that's also the topic of this meeting this year. It's about pregnancy, and many of you are really familiar with how pregnancy is protected. We know that, for example, alcohol leads to the fetal alcohol syndrome. That's why pregnant women are advised not to drink alcohol. Smoking women, their children are at risk, small for gestational babies, growth retarded, intrauterine death, preterm death. So these are risks, and therefore our pregnant women are advised not to smoke. And then there are physicians that say, okay, chemotherapy, which is a drug designed to kill rapidly dividing cells, that is safe. So I want to share with you how, what we tell, for example, Leslie here in the picture, to keep the smile while she's pregnant, receiving FEC, so 3 types of chemotherapy for breast cancer. Well, we tell Leslie, first of all, that if you give chemotherapy after the first trimester, there are no other or no major or no different or more congenital malformations when compared to the controls. We see here data that in red we have the major malformations, and we see that in our population there are some major malformations, but this is a patient that even did not receive chemotherapy. And in patients receiving chemotherapy, there are major malformations, but not different and not more when compared to controls. So that is one important issue. Subsequently, I want to share with you the data we published in 2015 and data we published just a few months ago that I do believe really changed this policy on cancer treatment during pregnancy. Because we tested our children very in detail. We did do general health, cognitive outcome, heart morphology, and functions on different ways. We did do that in 130 children. There were 2 important figures, and this is the first of the 2. If we looked into the cognitive outcome, there was actually no difference in study group and the control group. We could not, at the left, we could not see any difference between any subpopulation, any different type of drug or only radiotherapy. There were no differences. Also here at the right, we looked at the cognitive outcome in relation to the number of chemotherapy cycles, and we could not see that there's a difference if you received 1 or 2 cycles of chemotherapy or 6 or 7. So the number of chemotherapy cycles did not affect the cognitive outcome neither. But there was a difference regarding the prematurity. We received a cognitive outcome in relation to the gestational age, and we see that the cognitive outcome increases with gestational age. But importantly here is, this was the same for the study group as for the control group. So we know from this that preterm children do worse when compared to term-born children, but this is independent of chemotherapy. And from this figure, we can conclude that it's better to keep the baby as long as possible, even if needed with chemotherapy with the mother, rather than induce a preterm delivery and continue treatment afterwards. However, we should be careful with chemotherapy because, for example, cisplatin, we know that this can induce hearing loss. We had some evidence in our studies, and there's also a recent 2014 Dutch case report showing that the child had bilateral perceptive hearing loss when his mother received 5 cycles of 70 milligram per square meter cisplatin. So from this, we prefer actually to use carboplatin, which is actually an alternative that is commonly used. In the following, I want to share with you the follow-up study, which was presented at ESMO in 2019 and published just a few weeks ago. 130 study children with controls. 97 children were not only exposed to chemotherapy, but also to the stress associated maternal stress, imaging studies, and supportive drugs. I will just show the main results. Basically, if we look to the IQ, there was no difference in the full IQ between controls and study children. However, there was a difference in the verbal IQ, which was less in the study group, but there was no difference in the performance and the processing speed. Also here, in relation to gestational age. Basically, now we did not see any effect anymore on gestational age, and also there was no difference regarding the number of chemotherapy cycles. When we look to the memory span, actually there were no differences in these types of memory. However, there was children receiving chemotherapy did worse when compared when the visual spatial long-term memory was tested. What does that mean? Children received a page with images, a sheet of paper with images. They had to see which image was where on the paper. Then they had another task for 30 minutes, and after 30 minutes they needed to tell which image was where on the page. So that particular task, there was a bit less effective. The other memory tasks, there were no differences. So if we summarize this paper, there were study children had a worse verbal IQ, only 6 points. However, this was worse when the mother died. Then it was really significant, 15 IQ points. There was also a lower score for this type of memory I explained. However, there were no difference in the full-scale IQ, performant IQ, processing speed, memory span, short-term memory, attention and behavior problems, and cardiac dimensions and the left ventricular function. So the conclusion of this paper was that we should have pay special attention for the evaluation and additional stimulation of the verbal development in these children, especially then if the mother is in a poor condition and may succumb of the disease. A very recent paper of our group also doing functional MRI in these children. In red is the main message. Actually, there were some differences in local structural white matter and the gray matter difference, but there were no whole brain or functional differences in these children that were 9 years old. So more data, but also more safety data in older children. To conclude on the effects of chemotherapy on children, these are all children that were exposed to chemotherapy during pregnancy, and basically it is hard for us, even for investigators, to find any differences. Basically, we can reassure you, parents, clinicians, that actually we can consider chemotherapy administration during pregnancy. The last part is on the underscoring the importance of a multidisciplinary setting. We showed basically that there are less terminations, there is less prematurity, but there is more cancer treatment, and this results, the chemotherapy especially results in more small for gestational age babies, neonatal intensive care unit admissions. That's why we need these obstetric high care units where we can treat these children. I will not go into detail. We recently published like a stepwise care path, basically, when cancer during pregnancy is diagnosed. Those who are interested can look at it. One of the comments or the results of this multidisciplinary discussion is that, for example, for cervical cancer, we should tell patients or clinicians that patients should not deliver vaginally. They should have a cesarean section, because it can introduce, vaginal delivery can introduce episiotomy site metastasis that can be fatal. A recent New England paper from 2 weeks ago showing that even if a baby is born when the cervical cancer is still in situ, it can ingest cervical cancer cells that leads to bronchial metastatic disease in the offspring. So definitely there is a reason to do a cesarean section in these patients. And if we do this cesarean section, which you can see here, also at that stage, the oncologist can stage the patient. So that interaction between obstetricians and oncologists is very important. I want to invite you to join the INSIP. I think this collaboration adds and only actually allows to provide the data that we present. I want to repeat the take-home message. I hope I could convince you that chemotherapy is possible in pregnancy. Cervical cancer is the most challenging, and that we should discuss this interdisciplinary. I have to thank the sponsors that pay for our studies. We have a wonderful team, if I can have the... I want to thank the researchers in our group that all collect these data, and I mainly want to thank our patients that contribute also their children to our studies. Thank you. Una, I give the floor back to you.
I understand from the chat that there are issues with both Una and Liliana connecting. Liliana is coming back.
I see no questions in the public.
So if you go to Q&A, Professor Ammann, there...
Yes, okay. Is it possible that in future the role of radiotherapy will increase in the treatment of pregnant patients? Okay, that's a very good comment. I must say that in my clinic, I have difficulties to convince the radiation oncologists. Actually, many still do not believe that this is safe. And in many situations, yeah, it's still a challenge to convince the radiation oncologist. So I think we need more data and maybe more experts. Maybe it's because they are not really aware of it and they rather say, I prefer not to take a risk rather than investigating this into depth, or I want to avoid also these stochastic risks. But at least in the clinic, it's a problem to convince them. So on the other hand, we have to say that if you look to all the oncological treatment modalities, for example, surgery, chemotherapy, or radiation oncology, majority is chemotherapy or surgery. I think in a minority of cases, we in practice, we have to irradiate during pregnancy. So it's not so common, but if we have a clear indication, there is still the threshold of some radiation oncologists. However, I have to admit that we have also experts in our group that say this is definitely possible, but if you look at it in general, there is still some resistance.
I think I'm back now, if you can hear me and see me. And I apologize about that, Prof. Ammann. I seem to have lost the connection just near the end of your talk. So thank you so much for giving up your time to talk to us. And thanks to Marique for stepping in to ask some questions. I really enjoyed the talk. I liked the photo of your patient smiling with her ice lolly and during the chemotherapy. So this is a difficult area that you're working in. Thank you for your time. I will move on now to Marique, if that's okay. And I would like to introduce Dr. Marique de Saint-Hubert from SCK in Belgium. She's currently working at SCK focusing on dosimetry and radiation protection with a particular focus on proton therapy. And she's an active member of EURADOS Network Working Group 9. So I'd like to invite her now to speak to us today, the last talk of this session before the break, on radiotherapy during pregnancy. Thank you very much.
Thank you, Una, for the introduction. I hope everything goes well with the connection, but it seems to be okay. So I'm going to start my talk on radiotherapy during pregnancy. And this is the outline of my talk. So I will describe a bit the current clinical practice and data, although we've seen already quite a lot of examples. I will just briefly describe them, dig a bit deeper into the dosimetry during pregnancy radiotherapy. And then I will highlight some potential benefits from advanced radiotherapy techniques that could be applied during pregnancy. And finally, also, I will mention the EURADOS activities and plans. Okay, so clinical practice and data. 1 in 1,000 pregnancies are complicated with cancer, and more than 70% of these patients are being treated. But if we look at radiotherapy during pregnancy, there's only 3% of the patients that will receive radiotherapy. And it was already mentioned in the previous talk. It is not something that is done very much. And in the cases that use radiotherapy, this is mostly for breast and brain cancer patients. As you can see on the right table, in the first trimester, it could be a valid alternative for chemotherapy, because chemotherapy is not done in this timeline, and it could avoid as such treatment delays. But generally, radiotherapy is postponed until after delivery, and it's treated as a kind of prohibited topic. Why? This is because there's a lack of reliable information on the risk of fetal damage, also a lack of data, of those data for the fetus during the radiotherapy. And finally, there's also a big debate on what dose you could consider allowed. Okay, there is the ICRP threshold for deterministic effects. So generally a threshold of 100 milligray is used, but of course there is also a risk of cancer, and there no threshold is used. So this debate is still ongoing, and it's not an easy question to answer. So in general, general aspects of radiotherapy during pregnancy, if you look at the fetus dose during pregnancy, it will largely depend on the cancer position. You can see on the right picture that depending on the position, the distance of course becomes larger. So if you have a brain tumor, the distance to the fetus is of course larger. So, but in general, it's assumed that for upper body parts, radiotherapy is possible. Furthermore, the fetus dose will also depend on the stage of the pregnancy. So the first trimester, you can see also on the picture, the fetus is further away from its targets in the upper body parts, if you compare that to the second and the third trimester. And in general, it's assumed that before the third trimester, it's safe to do radiotherapy. It was already shown that fetal shielding for photon radiotherapy is applied, which can lead to a dose reduction up to a factor of 4. To do so, heavy materials are used, and you can imagine that strong supports are needed, and they may be risky also for the patient, of course. So this is something to consider. And then, besides these very strong supports and the building blocks on top of a patient, you can also use lead aprons, but of course that is not very comfortable for the patient. Now this is regarding the dose coming from the radiotherapy itself. But what about imaging in the radiotherapy process? Actually, this is showing the whole radiotherapy process and where imaging is playing a role. So we have, in a first stage, you have diagnosis and staging of the disease. There, CT or PET-SPECT CT could be used, and we already saw yesterday that could lead, of course, the nuclear medicine examinations could also lead to quite a significant fetus dose. Then there is the planning of the actual radiotherapy, which needs usually CT. There are some there are developments to have also MRI plannings, but today mostly it's done with CT, which of course gives quite high doses. And then there is, during the setup of the patient, there is also onboard imaging used. So the patient is being positioned appropriately using onboard imaging that is really on the machine itself. And then later on, of course, follow-up is also used. So imaging also plays an important role in this whole process. But if we take a closer look to the clinical fetus dose data that are existing, there are only a few studies reporting on fetus dose and outcome. And one of them is a review paper from Kal et al. Reporting on fetus dose during pregnancy photon radiotherapy. And this is actually a review paper, so summarizing a number of different papers for breast carcinoma, Hodgkin's disease, and for brain and head and neck tumors. And what they reported is that the fetus dose for breast carcinoma was between 40 and 180 milligray. For Hodgkin's disease was between 9 and 500. And you can imagine for the brain, the dose was a bit lower. It was between 3 and 90. It was shown that the breast and the Hodgkin's disease, always shielding was used, but for the brain, head and neck, it was only done in one case. Now, generally, we can say that the outcome of these of the children are reassuring. So all have delivered a healthy baby, but long-term follow-up is limited. And this is generally the case if you read throughout the literature. So there is not a lot of data on long-term follow-up during pregnancy radiotherapy. Furthermore, the AAPM guidelines require the estimation and the reduction of fetus dose. And so it is important in a clinical setting to perform experiments in phantoms and or using Monte Carlo simulations and to estimate the dose, which is why I'm going to dig a bit deeper into the dosimetry performed during pregnancy radiotherapy. So if you look into photon radiotherapy, the out-of-field doses have 3 different sources. So first, there is the photon leakage, which is through the treatment head of the machine. Then you have the radiation scatter coming from the collimators. And then the third component is the radiation scattered within the patients, which is shown by the red arrow here. And looking into some of the studies, the comparison of experimental working group 9 data to the analytical model showed differences and showed that the out-of-field dose depends largely on the treatment device. So you can have a Siemens, a Varian, an Elekta. So there's clearly a difference, mostly because of a different leakage and of course scatter in the collimators. And also the treatment technique will of course influence the out-of-field doses. Conformal radiotherapy is not the same as an intensity modulated radiotherapy. These out-of-field doses largely depend on the technique used as well. So all these studies until now, they were performed within phantoms to estimate the out-of-field doses using water phantoms and anthropomorphic phantoms. But for pregnant women, no commercial phantom exists. And it was already shown yesterday that people are being very creative to develop such pregnant phantoms. Well, one thing is to use a water phantom, but of course there no geometry and tissue composition is specified, so it's just water. And you could use the rando phantom just for the first stage of pregnancy. That could work fine because you could use the uterus dose as a sort of measurement of the fetus dose. But when you move to different stages of pregnancy, of course, you need to create a belly. And some people have tried to create such a belly by using PMMA or lucite slices, as you can see in the example on the right upper corner. And in these lucite slices, you then can insert detectors. And another technology which I would like to mention is the 3D printing technology. And some studies have shown already that with this 3D printing, you can even print very small structures, and you can print, for example, fetus organs. So you could go even deeper than just looking into the fetus dose, but looking really into smaller substructures and organs of the fetus, which is, I think, a very interesting technology. And it could even lead to individualized phantom developments, because nowadays you can even print phantoms. I will highlight that a bit later. What is done in the clinics nowadays, as I mentioned, people are being very creative. So usually the slab phantoms are used and are positioned between body structures, or sometimes a water phantom is introduced from the for the belly. And in this example on the left down, you can see that even sometimes water bottles are used. So combination of different phantom pieces. And usually TLDs or ionization chambers are inserted to measure the fetus dose, and sometimes also to measure the skin dose. So that you can have a conversion between skin and fetus dose that can be used during the in vivo dosimetry. I will explain a bit later. Many groups are optimizing the treatment based on these measurements. So for example, you can optimize beam parameters. You can optimize the positioning of the patient and verify if this position influences the fetus dose. You could check how patient shielding can best be positioned, etc. So this is something ongoing. And we even saw a presentation in the working group 9 group last week on bladder filling, that perhaps the filling of the bladder may also lower the dose to the fetus, which is a very nice thing to optimize the fetal dose, I think. So besides doing experiments and measuring the fetus dose experimentally, you can also use computational dosimetry techniques. But the problem is, if you want to do that on patient data, that the area that is scanned for the treatment is usually limited. So if you have a brain cancer that needs to be treated, the only imaging area that you will get is from the brain. So you will not have any anatomical information from the fetus, as you want to avoid also scanning the fetus, so not to deliver too much dose. So you have to make use of computational phantoms. and they were already highlighted yesterday. So one is, I would like to mention, is the one developed in Munich. It's the Katja phantom, which is 24 weeks age of pregnancy, and was kindly provided by Munich for our research. And then there is the whole phantom library from the University of Florida, who has really different stages of pregnancy, going from 8 weeks of pregnancy until 35 weeks after conception. And also this library was provided for our research. This is also the phantom library that will become the ICR, will become public in the next ICRP publication. So finally, this is all for experiments that you can do prior to treatment, but once the patient is being treated, you can also place some detectors to perform what we call in vivo dosimetry. You can place dosimeters on the belly, as can be seen in the example. So passive detectors could be used for that, and then you can assess the skin dose and make the conversion to have an estimate of the fetus dose. Of course, this doesn't allow you to optimize the treatment, but it can be interesting to follow up these patients, to know the dose and to follow up these patients later on. So this is an example of a sarcoma patient receiving radiotherapy, and here you can see a brain irradiation of a 37-year-old woman being treated for papillary meningioma. So this is all data that I received from Warsaw Group, who performed this experiment. So with this, I give a sort of introduction on how dosimetry is performed in photon radiotherapy, but I would like to discuss with you a bit the potential benefits from the advanced radiotherapy. And therefore, I would like to discuss with you the proton therapy technology that could be eventually beneficial for pregnant women to be treated. So first of all, protons are slowed down as the beam enters the target and releases its energy at a tunable depth. Therefore, as you can see on the right picture, protons have a decreased entrance dose and they have almost no exit dose. So there are clearly advantages compared to photon radiotherapy. And few data exist, but from one of the studies that are out there, they report on a 10-fold reduction in fetus dose during pregnancy. So this is an example of a brain irradiation where the dose to the fetus was between 1.5 and 2.5 microsieverts per gray, that's normalized to the target dose. So you have to multiply by 60, for example, to know the total dose given during this irradiation, compared to the photon irradiation, which is in this case a 3D CRT, so a conventional radiotherapy, which range between 11 and 30 microsievert per gray in their calculations. So this is very interesting data that looks very promising for pregnant women to be treated perhaps with proton radiotherapy. However, only limited data are existing. And so there's a lot of research and those data still that need to convince people to move towards perhaps proton therapy during pregnancy. The dosimetry challenges during proton therapy are, well, they're challenging. First of all, protons are interacting with the beamline and the patient, thereby creating secondary radiation, which is far more complicated if you compare that to photon radiotherapy. Because this is a mixed field of radiation, and it will consist of not only photons, but also secondary protons, alphas, and neutrons, all with varying radiation qualities. They have contributions to the outer field that will depend on the position where you are out of field. So the closer you are to the target, the more secondary protons you will have, the more photons, but the further you go, the more neutrons you will get. So it will depend on the out of field position, the patient orientation, the beam parameters, etc. And more particularly for secondary neutrons, they have a whole energy spectrum. So you have high energy neutrons that can be created up to the energy of the highest energy of the protons that you use during the treatment. You have fast neutrons evaporated by excited nuclei, and you have the thermal neutrons, which are slowed down during the collision. Now, for this reason, also detectors for out of field dose measurements need to have very specific detector material composition. This is required for neutrons to interact. So the thermal neutron detection, for example, can be based on lithium-6. Or the fast neutrons that create hydrogen that create recoiled protons in hydrogen-rich materials, such as the converters used in CR39. not only they need to be very specifically made of a certain material composition, they also need to be compact if you want to measure them in vivo, in a phantom, for example. So you can use lithium-6 enriched TLDs, but also CR39 can be used, and bubble detectors, even though they're not so small, but they can be used also. And we've been studying these detectors already for quite some years now. And we have characterized by now also its response, angular and energy dependent response, but it's something that is challenging and needs to be considered for the dosimetry, out-of-field dosimetry during proton radiotherapy.
Marique, sorry, could I interrupt you and just remind you about the time, if we could just have 1 or 2 minutes, and I'm sorry because it's a late start. Thank you.
Sure.
Thanks.
Okay, I'll briefly mention that in Monte Carlo simulations, the modeling of neutrons is also very challenging if you go above 20 MeV. And the dose quantities that we would like to measure in out-of-field proton radiotherapy is not the H*10 as is shown in one of the examples, but is organ dose equivalent. And this is something that we've been studying for some time in EURADOS Working Group 9. So what we know is that proton therapy compared to photon radiotherapy has a few orders of magnitude lower out-of-field doses, and this is very promising again. So this experience, we would like to use that in the future activities, and I'm still going to take some time to just explain to you what are the plans for working group 9, 6, and 12. So we have set up a sort of collaboration between 3 different working groups. We, as working group 9, collaborate with working group 6, mostly on the Monte Carlo simulation framework, but also to set up the computation of phantoms, to do the Monte Carlo modeling, to define the beam parameters. Then we would like to have, of course, phantom measurements, and finally also the working group 12 collaboration is important for the imaging doses. So very briefly, the status now, we have been doing some exercises with the SEKCN. There is Mefos, Vojje, and Kasia from NCBG. We have already started to do simulations of proton radiotherapy in the brain and comparing different codes to estimate fetus dose. These are the first preliminary results. What we noted is that, okay, you have to unify the cross-section libraries and models within the codes so that you have a good agreement between the codes. And we noted quite large differences. So here you have, for a treatment of 60 gray target dose, you have doses from 20 to 40 microsieverts. And there was quite a big difference between the 2 phantoms. So we are still investigating this. The next thing is to go to a more clinical case. And so we would like to simulate the fetus dose in a breast plan, which was performed by the Danish Center for Particle Therapy in Denmark. And so Lynn and Maria, they made a plan on the Florida CT DICOM data, which is quite a complicated irradiation. It's a breast plan with 6 lymph nodes. We would like to do the simulation in TOPAZ and compare also with MCMP. Just if I can, for the measurements, we are going to develop a phantom within EURADOS. There's a lot of efforts being done on BFS, Sebastian Finkel. They have a 3D printer, which they would like to print the pregnant phantom and the fetus. We are currently testing, they are currently testing the printing approaches and the materials. And there's a lot of interest within the Working Group 9 to participate in these measurements. And of course, also like to mention this methodology that needs to be put in place to combine detector measurements, which is something that was granted by EURADOS for Miguel's work. So thank you for that. And the last point is the Working Group 12, focusing really on the dose for imaging. That is still also an ongoing task in general, but more specifically also for pregnancy related to the medical exposure in the imaging part, which is Dario, and then leading that task. So finally, I think it's a good, I mean, we start up this very good collaboration of different working groups, but we also need a collaboration with the hospitals to have the different pregnancies, the pregnancy stages. We need to execute the clinical plans, to optimize these plans, include imaging, to host some measurements perhaps for intercomparison, and even in the future, but that's far future to move towards individualized dosimetry approaches. So this is the end of my talk. Thank you very much for your attention, and thank you all the colleagues from EURADOS for their input. And yeah, thank you. Sorry for being a bit late.
No, it's okay. Thank you, Marie. Thank you so much. And sorry for the reminder. I am conscious for some of our technical reasons, we probably got a little bit delayed on the schedule. So thanks for your understanding. So I think we just should move now straight to the break. Just remind people you can stay logged in and you can watch some of the sponsors' commercial presentations during the break, but we're going to break for 25 to 30 minutes to return with the round table between, I think, 16:55, a few minutes either side of this. So if you can, I'd just like to say one more time, say thank you to all of our presenters from this session, and we hope you enjoyed it. Thank you.
Hello. Ελευθερία, μ' ακούς? Okay.
Hi, everybody.
Do you hear me?
Hello.
Hi.
Hello.
Can you hear me?
Yes.
Can you hear me? Yes. Okay.
Yes.
I just had a brief message that my microphone is not transmitting data, but obviously it's working.
Hi.
Hello. Can you also hear me?
Yes.
Thank you.
Geraldine, can you say something?
Yes, sorry. Yeah, can you hear me?
Okay.
Yep. Sorry, thank you.
Okay.
Okay. Welcome back for the final part of this winter school. I think we have had in the first 3 sessions of this winter school a very excellent series of presentation. And for the final part, we have organized a round table to further discuss the topics that we have addressed during the lectures, the topic of fetal radiation risk. And when we were organizing the school, we were hoping to have a live event in Belgrade. And so this would have been a much more lively and much more interactive exchange during the round table. Now, with this online event, this will be a little bit more difficult. We are obliged to go virtual, but I'm still confident we will have a nice, lively session. I've seen in the last days we have had several questions on our question and answer block on the right side of your screen. So please feel free to continue to write your questions there. And I think to start, we try to know each other better. And we had at the beginning, asked you at the beginning of today's session, we asked you a number of questions in order to know better how is your audience. So now I ask Babs or Kerstin if they can share the results of our poll. So the first question. Yeah, the slides are arriving. I thank Eleftheria for preparing and analyzing the data of the results. The first result is whether you are a EURADOS member or not, and we have a half and half of attendance. And as Liliana said, if you're not an EURADOS member, maybe it's a good occasion this winter school to think of becoming a EURADOS member. The second question is about the type of organization you work in, and nearly 50% of you are working in a hospital, and about the same amount in a regulatory authority or in a research center, 8% in educational institute, and 10% in another issue. Then we were asking you what is your position, and reflecting the distribution of the institute where you work. About half are medical physicists, 27% are researchers, and then 7% are regulators, and 15% have said that they have other backgrounds, and only 1% each for medical doctor or technologist or nurse. And finally, we have asked you if you have experience in performing estimation of dose to embryo or fetus. 35% of you have had this experience and 65% no. And of these 35%, more than half do it less than once in a year. About 20% do it 1 to 3 times per year, and 22% do more than 3 times per year. So I think it's a good overview of what is our audience. And now that we know our audience, I think that we can switch off the slides of the poll, and we get to know the participants of our round table. So I would like to ask first to the participants in the order that they appear on the screen. Can you please turn the slide off? Thank you. And I would like to ask starting from Geraldine, if you just can introduce yourself and telling us just what is your position and what is your work.
Okay, thanks, Augusto. So I'm a medical physicist and I work in a large academic teaching hospital. And in that hospital, we have a large diagnostic radiology department. So we don't have radiotherapy other than radionuclide therapy. So along with my other medical physics colleagues, we support both the radiology services, but also services outside radiology that use ionizing radiation. So I've been working in this area for more than 20 years. Thank you.
Okay, maybe we can move. Yelena, maybe you can introduce yourself as well. Hi.
Okay, hello everyone. My name is Jelena Pajic. I'm from Serbian Institute of Occupational Health from Belgrade. I'm a radiobiologist, skilled in biodosimetry and cytogenetic research. And I worked this job for about 15 years. However, I am familiar with the fetal radiation risk and radiobiological effects on fetus. And since I'm working at the Radiation Protection Department, I have colleagues, medical physicists, skilled in dose assessment and patient dosimetry. And related to this winter school, I just have to say that together with them and our colleagues from Vinča Institute of Nuclear Sciences, in 2019, we plan to start a big national campaign with the main goal to inform medical personnel involved in exposure of pregnant patients on fetal radiation risk, and also to provide them guideline step by step what should they do before, during and after exposure of pregnant patients, because we don't have a national guideline. At least we don't have all rules and steps in one single document. However, this COVID situation stopped us at the very beginning, but luckily for us, this winter school and great presentations we heard in last 2 days helped us to improve our knowledge and, of course, to hear from colleagues from other countries how do they manage this kind of exposure.
Okay, thank you very much. Maybe we can move to the next lady. Anne, can you present yourself as well?
Good afternoon. My name is Anne Fremont. I have a background in physics, but I work since 2003. I work at the Belgian Federal Agency for Nuclear Control, which is the Belgian regulator in nuclear safety and radiation protection. And there I have been working on the domains of medical and occupational exposures and public exposures. I'm also active at the international level, for example, in HERCA, RASC, and EC Article 31. At FANC, we receive notifications of accidental exposures of pregnant women, mostly by the radiologists or the physicists that are involved. And on the other hand, we also receive questions from the pregnant women or their family members. Of course, we have transposed the European directive in our regulations, but also we pay a lot of attention to the communication issues. So therefore, we have an information file on our website with some guidelines for the practitioners and also other medical doctors and medical staff. And we have developed some material to communicate risks and also the importance of notifying pregnancy to the women, such as flyers to distribute in waiting rooms and also posters for the waiting rooms. But as we know that posters and flyers don't always attract the attention, we also developed a small movie that can be shown in waiting rooms, for example, at medical practices and so on.
Okay, maybe we can see the movie later because we're trying to get Augusto back. Okay, so maybe we can say a few things. Dario, can you introduce yourself as well? Augusto is here. You're muted, Dario. Maybe you can your microphone. Okay.
Hi. Good afternoon to everybody. I hope you hear me now. My name is Dario Fai, and I work as a professor of medical physics at Medical Faculty of Osijek. This is within University Hospital Osijek in Croatia. In fact, my background is from radiotherapy department of that university hospital where I worked for over 15 years. Since at that time, in fact, we did not have any physicist involved in radiology department. We had some of the duties there, and this is the reason that in the last years I was oriented mostly to diagnostic radiology. And so this is more or less I work as a medical physics expert for a number of small hospitals and some university hospital, and also I work as a researcher in this field. I'm also part of Article 31 group of experts. And just to say, should I say something about situation here in Croatia briefly, or?
Maybe we can just present the other of the roundtable discussion, the other participants. We have from Germany as well, Professor Holger. Yeah, can you present yourself as well? Thank you.
Yes, hello.
Hi.
So my name is Holger Klammer. I am from Germany. My background is that I'm a radiobiologist. I did a lot in radiation research, and at the moment I'm working for the German Radiation Protection Office as a specialist on radiation research and radiation effects, with a focus on medical care or exposure in medical care. So I am assessing and communicating radiation risk from exposures from medical examination and treatments in medical care, including especially exposures of pregnant women, but also occupational exposures or exposures during flights, so tourists.
Okay, thank you very much. And for the end, maybe Sotiris, can you introduce yourself as well?
Hello also for me. First of all, I would like to thank you very much for the invitation to participate in this roundtable. I'm very glad for that. I'm a medical physicist. My background is medical physics, and I worked for the Greek Atomic Energy Commission for the last 20 years. Most of this period I was working for the Department of Licensing and Inspection, and especially for the authorization of medical applications of ionizing radiation, medical radiology applications. And for the last 3 years, I work for the Department of Education and Training, and I'm the course director for the BGC running in Greece. I have also to say that I'm a member of a special committee operating in the Greek Atomic Energy Commission with dealing with this issue of inadvertent exposures, consultancy meeting which provides advice to pregnant women, and not only, also to physicians, gynecologists, and make and additional activities I could describe later on.
Okay, thank you. And finally, my name, as you can see, is Eleftheria Karinu. I'm also a regulator. My background also is a medical physicist, and with Augusto, I'm moderator of this roundtable discussion. I'm going to help Augusto. I'm going to give the floor again to Augusto. So we had only this small introduction, and you can move on, okay?
Okay, thank you very much. Sorry, but I was kicked off from the system, but it seems now I'm back again. Just to finish this round of presentation, my name is Augusto Giussani. I work at BFS, the Federal Office of Radiation Protection in Germany, as Holger. And my background is physicist. I'm internal dosimetry mainly. And so that's about me. And now I would like to start the first round asking our roundtable participants to tell us a little bit about how is their experience with exposure of female patients during pregnancy, and what are, for example, people who turns to you for asking advice, which is the information do you provide, which is the information which is expected for the person who comes to you for asking advice, and if you're doing assessment, if there are any standardized procedures, guidelines according to which you do these assessments. And I think we can start with Anne. She has a short video to present. So please, Anne, if you want to start.
Okay, so as I already said during the short introduction, we receive, as a regulator, we receive the notifications of accidental exposures. Currently, we receive about 20 per year, and we think it's an underestimation of the real number of cases, of course, because there are only a limited number of hospitals that are notifying for the moment. So we think that there must be much more than that. And apart from the notifications, we also receive some questions of the pregnant women themselves. There is a dedicated email address and a dedicated web page that has been foreseen for that. So we try to reach not only the practitioners and the physicists, but also the referrers and the patients or the pregnant patients as well. And therefore, we developed some communication material which is available on our website, because of course you can try to reach pregnant women at one time, but in a few months it's another set of people. So we have to continue this the communication. And the movie that was produced is available also for to set up in waiting rooms at medical practices, and also pharmacists, for example, you can use it, or in the bureaus for child well, the specialized bureaus for pregnant women, for and so on. They can be made available.
Okay, maybe we can start the video if this. I suppose it is available also in other languages or only in...
For the moment, it's available in French and Dutch only. But of course, if it would be used by other countries, we can look into it to make other languages available. But so the message is clearly to speak to your doctor on when you think you might be pregnant, or you are not sure that you are not pregnant.
You said that you produce and prepare communication material. Do you prepare it only in this case to prevent the fact that pregnant person are exposed to radiation, or do you have also some counseling, some advice on how the doctors have to deal with the patients after the exposure, after the accidental exposures?
Yes, of course, the focus is on prevention first. But if there has been an exposure, then the advice, of course, to the pregnant woman is to talk about it to her doctor. And the advice to the doctors, of course, is to investigate if there has been what was the dose, what's the risk associated, and also what can be done in the future to avoid this type of accidents.
Okay, thank you very much. Then we can move to Sotirios. I think you also have an experience from a regulatory point of view.
Yes, we have an experience of about 20 years. In 2000, we established this special committee I mentioned when I introduced myself, and this committee was established because we found out as a regulatory authority that even if you have the best regulatory legislative framework in the world, or even if you perform inspection and enforcement as regulatory authority in the best way, it's not the most effective way to control this issue of inadvertent exposure. So we created this committee, and when this committee became known to gynecologists and other physicians, pregnant women started to contact us in order to get advice and information about issues related to the exposure of the fetus to radiation. I have to say that for the decade from 2001 to 2011, about 269 pregnant women contacted EAE in order to get advice. Most of these cases concerned X-ray examinations, plain radiography examinations, and in most of these cases also the fetus was outside of the radiation field, so as you can imagine the risk to the embryo was really, really low. Additionally, I have to say that Greek Atomic Energy Commission has prepared informative material not only for pregnant women but also for the physicians in order to enhance awareness on the issue, because we found out during our investigation that in many cases pregnancy was not investigated properly before the medical exposure, and that was really a very big issue. Additionally, after 2010, we created in our website a frequently asked questions area with a number of questions already set by pregnant women to us. And I have to say that from 2015 to 2020, around 62,000 people visited this area to get answers in related questions. I don't imply that all of these people were pregnant women exposed to radiation, probably, but you understand that this is an important issue, and of course people wanted to get information about the risks associated with this kind of exposures. And the good news is that as we continue to investigate with a follow-up research what's going on now, from 2011 to 2020, we have only about 123 cases of pregnant women conducted EAE. That means that on one hand, that the situation got better, on the other hand, that the additional means used, like the website, worked well as well. Thank you.
Thank you. And we can maybe shift to Holger, which has may have a similar experience from the German part. To see how there are similarities and the differences.
Yeah, yes and no. So there are some similarities, but also differences. So the German Radiation Protection Office is not surveilling practice and medical care. So we are a professional body, but we're not a surveillance authority. So we are commissioned as professionals to inform citizens about radiation protection issues. And that is what we do. So we offer general information in a couple of brochures on various topics. And one of these brochures, for example, is on radiation risks during pregnancy. But we are also available by mail or by telephone. We have contact formulas on our website, so we hope to be easily accessible for the public. However, we are not. So we're not a clinic. We're not a hospital. We're not a surveilling authority, but we try to assess issues. So we deal with, as I said, we deal with occupational exposures during flights. But one major issue is the exposure from examinations and treatments and medical care. And the need of the patient is actually covered. That's what we heard in other presentation as well. So the physician is obliged to inquire whether a patient of childbearing age is pregnant or could be pregnant, needs to take this into account for a justification of a procedure, and inform patients about risks and benefits of the examination or treatment accordingly. So basically this is done. However, sometimes examinations or treatments are needed despite the patient being pregnant, or sometimes the woman is not aware of being pregnant during the examination. And in some cases, we have seen in Geraldine's talk, we have seen the very strict precautions that there are. This is, I hope this is usually set up in all hospitals, but sometimes these fail. So pregnant women who underwent who are exposed, they often have a comprehensible concern, anxiety, or even fear. Sometimes this is a very emotional situation. Sometimes these women need reassurance that they didn't hurt the baby, so there's also some guilt involved. And we try to offer an additional help or a second opinion on the topics, because sometimes we made the experience that these women often do not trust their doctors, their practitioners. There is some sort of distrust, and so these women try to Google some other way to get help and information, and we try to be readily available for that. That's what we do. So we do not have a lot of inquiries. We have a statistic made. We have about 100. We had in a time frame of 5 years, we had about 100 inquiries, so about 20 a year. That's not so very much. So we do not have that tremendous amount of inquiries and consultations that others might have. Good.
Thank you. And maybe we shift to hospital settings. So maybe Geraldine, you want to say something?
Well, I suppose I would have covered a lot of the approach in the presentation I gave earlier. So for those that were listening in, I mean, in a hospital, we look first of all to the legislation and the requirements for what we have to do. And then in Ireland, because we found it that they weren't maybe explicit enough, the legislation or the guidance documents, we work together with all the professions to get a policy document, and we try and apply that. So I suppose the approach in hospitals is to schedule patients appropriately, so that we avoid inadvertently exposing a fetus. And I suppose going back to what some of the other speakers said, and what we find with our regulators, they really want to know, could you have done anything differently if we did, if we do inadvertently expose a fetus. So I'd say, the challenges still arise, and I would have mentioned some of those in the talk. The referral pathway, is difficult for certain groups of patients. What we do try for our referrers is to make it as easy as possible for them to give us the information that we need to appropriately schedule. So if you have an electronic requesting system, you can build in mandatory questions that the referring clinician must answer, which raises awareness about the issues, but also allows us to get the information that we need to schedule the patients. This can be more challenging when you're dealing with external referrers, so from GPs, etc. So there is a need to work together to make sure that all your referring base understand what it is you're trying to do. And then within the hospital, we have we work towards, with the national policy, we've amended it for our particular use in the hospital, so it reflects our equipment, our patients, our practices, and we make sure that those working in the department, our radiographers, radiologists, that we all understand what it is we're trying to do. So we have standardized forms, we have regular meetings, we have protocols that are available to people, and then when something goes wrong, we do a look back and just to increase awareness, if there is something that we could do differently, that we do it, or if there are things that are just very difficult to manage and particularly challenging, that we make sure that everybody is aware of that. So it's hard to give a quick answer, because this, it's a topic that, as soon as you think you have something that covers all situations, something will come that is difficult. But I think what I would say, and I was really interested to look at the participation in the meeting, and we have a lot of physicists, we have a lot of regulators who have a physics background, and you know, we don't have as much engagement from some of the other professions. So I think while the underlying physics and understanding of risks is really important, I think it's a much bigger issue, because at the end of the day, this is a patient and this is just one risk. And we need to manage that appropriately, but we need engagement from all the stakeholders, and we need to consider the patient as an individual, and how to make sure that they get the care they need at the appropriate time. So you know, I think that's something that we need to improve on, really, just getting engagement from other stakeholders to make sure that that we do this as best we can.
Okay, thank you. There is still this small technical delay for switching on the microphones. Yelena, you want to be the next one?
Okay. In Serbia, we don't have a national committee or commission or anything like that. Those assessments of pregnant patients we do in our institute, in Radiation Protection Department, and also at Winter Institute of Nuclear Sciences. We have similar organization. And most notification of such exposures we get from pregnant women, from pregnant patients, and also from occupational exposed pregnant persons. And we do those assessment. Besides those assessment, we get them associated risks, and we also advise them to go to genetic counseling for further following up, medical following up. And I must say we don't have rich statistics. We have maybe up to 10 patients per year, and we also are aware of the underestimation of this number, but that's because we don't have a national guideline or some kind of national procedure. And as I said in this introduction, we are trying to establish a guideline for every step on the way, from the beginning to the end. And we think we make it easier for everyone. So during this preparation period, we established a really good connection with and cooperation also with a lot of hospitals in Serbia, and they are really aware of the situation and willing to help us in communication, and also they are willing to listen to this all we have to say about fetal radiation risk also, and to apply everything in order to follow patients from the first step before exposure, and during exposure, and of course after exposure. That's it.
So now, Dario, if you want to say something, I can maybe also add one question that was put in the Q&A today. Actually, the question has already been answered by Geraldine, but I think it could be interesting also to discuss it here in the round table, and it deals with emergency exposures, which are life-saving interventions, but also are causing significant doses, and how is the role of the medical physics experts in these issues, if there are some experience on it, or how is it managed?
I will start first with situation in Croatia, in my hospital. So the thing is that the regulations are really not explicit, so there are quite diversity of practices in Croatia. And for example, it starts with when patients come to the radiology department. For example, in my university hospital, we just have signs or to for the patients to say if they are pregnant, and they are asked by a person who is from the radiation technologist, and then the patient sign informative consent. This is the only thing, and this satisfies the regulations. But in fact, in the other smaller hospital, they are using 10-day rule because they don't have so much problem with appointments. Our physician, they are afraid of it. So when with 2 months or 3 months ago, we decided in Medical Physics Association to start to initiate activities about national guidelines. And when I saw a robust system that Geraldine showed us, it will be great thing to show to the others. Probably they already know it. So we will try. We already contacted all relevant professional societies and regulatory body. They are positive replies. So we are hoping in 2 months, maybe a little more, to have some national guidelines that will at least harmonize the practices. So this is the first step. The second is what my experience with the patients who underwent the pregnant patients that underwent the radiological procedures. In fact, I have one case here, and this is maybe 1 in 5 years from nuclear medicine and 4 from radiology, from diagnostic radiology. The thing is that 15 years ago, we made a large campaign including in radiation protection education. We included, in fact, ICRP 84 presentation. So we try to make more education for all medical practitioners and even general practice doctors, but this was much less. And we have practiced that if some irradiation of pregnant patient will be done or has been done, the advice of medical physics expert is always asked about estimation of dose. And in fact, physicians, medical practitioners are the ones who communicate the dose and risk to the patient. Mostly this is, in fact, reassuring the patient that the dose is not high to even think about termination of pregnancy. So, but most of the times the medical physicist is also present to back up the physician if this is needed. This is, in fact, how it works in Croatia, but we don't have national guidelines. This is more or less decided from hospital to hospital, but since there are very small group of medical physicists, we are doing more or less. So the second question was I cannot find it.
There was a question in the Q&A about the issue of emergency exposures, which are life-saving exposures, but they are causing also significant doses. And how is the role of the medical physical experts there?
If it's urgent, usually medical physics expert is not even there because sometimes it's in the night or something. But mostly, if it's urgent, the advice is not asked. Just usual measures of optimizations are taken because of the urgency. But afterward, the advice of estimating the dose and risk of physician medical Okay, there is in urgency. I don't think there are even justification is much more easier to think of this situation.
Geraldine, maybe you want to summarize what you have already written in the Q&A?
Okay, yeah, so I mean, it does happen from time to time that a pregnant patient will be referred for a procedure, and at that time the medical physicist is likely to be asked about the likely dose and can assist giving an estimate, which can feed into the justification. Now, in my experience, the interventional radiologists, cardiologists, gastroenterologists, they don't tend to do a procedure lightly on somebody who they know to be pregnant. So when that patient has been referred, you really are looking at something that they consider to be urgent. What we're doing is giving them an estimate, and then post-procedure you can do more complete dosimetry and just see what the dose was, and that can be used by the clinician if they're talking to the patient afterwards. I mean, I think very important for this is that it sort of shouldn't come out of the blue. So what you really want in these situations, because as Dario says, it can happen any time of the day or night, you want your clinicians to be familiar with which technology gives the lowest patient dose and then fetal dose. What are the optimization measures that they should be using anyway? So to have a well optimized system, and then working with the radiographer, who's really important in this area, and the physicist to see are there any additional optimization measures above and beyond those that they apply anyway. And there sometimes are measures that are appropriate to the procedure. So, you know, I think definitely there is. I think the question was, is there a role for the medical physics expert? And there definitely is, but also to make sure that you have systems ahead of the emergency procedure that are robust, so everybody knows what they're doing when this happens.
Okay, can I ask?
There was another. Please, Frederick, sorry.
No, go ahead. Augusto, go ahead.
Okay, because there was another question which I found interesting in the Q&A, and it was how you deal with. We have had today this presentation about young women, so 14, 15 years old, how to deal with her, but how do you deal with elderly female patients who could still be pregnant even at older ages? And for them, I think the natural risk in the pregnancy is higher than for younger people. Are there approaches to that issue? This is something I would like just to throw these questions. Feel free to answer if you have an answer about it.
I can give a little bit of experience because Aisling raised this after my presentation, and I think, you know, she made a very good point about looking at the incidence of pregnancy in that age group, and just look first of all to see, you know, do we actually have an issue that we need to solve, and is our age range appropriate? So in the national document we're using 12 to 55, but that's given as a guide. So I like her approach where you look at the incidence and you do a risk-based approach to see whether that's appropriate for that group, because definitely we've had challenges here trying to apply, you know, our normal tools such as the 10-day rule to this group, and then you're into having to waive the 10-day rule, and you know, I think it's definitely something that warrants another look. And it's not prescriptive in the legislation, neither European nor national legislation is prescriptive about the age range. So what it says is that we should ask the pregnancy question if it's relevant. So I think taking the approach that Aisling outlines for the younger patients, you know, could be one that would be very useful in our older age group. But for the moment we apply it, but I definitely would be interested in looking at that.
Okay, and I would also like to ask Anne, maybe because it's the country that there are many different languages and people coming. I mean, Brussels, Belgium is the heart of Europe. So is there a problem there with the different languages you mean? I mean, when the people want to get some information from the practitioners, from the website, from the social media, etc. Do you think that there are problems understanding the information given, or do you have plans for this?
Yes, we know that that it can be an issue when there are lots of languages involved. So I think it's important to provide the material also in a non-verbal form, and to try to reach the people at different through different ways. So not only with flyers or whatever, but also on social media, like you say, also on, for example, we participate in expos that are dedicated to pregnant women. You nowadays you have some expos for marriage, but also for baby things. So we try to reach them at different ways, and it's important to always bear in mind that the people are not talking the languages. So maybe, for example, you can provide some pictograms to make them aware, not only words.
Okay, and maybe another question for those who are trying to assess the effective dose or the committed effective dose. Can we say a few things about the tools that are used? I mean, yesterday there was a very nice presentation by Natalia, and some tools were presented there. So maybe do you have any experience in this? Can someone say something? So Didi, do you have?
Well, maybe I can.
Okay.
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 Darius can finish.
Yeah.
Okay. So in fact, when I started to work, it's we calculated mostly by hand. We estimated those to the conceptors mostly by hand, and it depends on, in fact, on a procedure that has been done. For some low dose procedures, we just used the rule of thumb that Natalia yesterday showed, or just typical doses from ICRP 84 or some other literature. For some high dose procedures, we calculated it or even measured it using some simulating the procedure. For some fluoroscopical procedures, at that time we tried to simulate it and to measure it into the phantom. It is quite rare, so we couldn't do it. But today we mostly rely on code software. Also showed yesterday by it's produced by Professor John Damilaki's group, and this is free, web-based, and it's quite user friendly. So most of our colleagues also are using this. So this is in fact how to do it. In fact, it was shown before yesterday. This is yes.
I could also
yes.
add the experience we have. I agree with Dario that in many cases we use the commercially available or on the web available codes for estimating the dose to a uterus and then to, let's say, to fetus. However, after all these years, we had many cases where we had to contact medical physicists in large hospitals and clinics in order to collect information about the exposure of the pregnant woman and the embryo. And in other cases, we had to go there and perform measurements in order to be sure that our estimations are realistic. However, we are very lucky as a regulatory authority that we have in our database data concerning the performance of the equipment used for performing the exposure. So in many cases, of course, we used this data in order to estimate doses to embryo and then be capable of estimating the associated risk. Thank you.
Thank you. I've seen there is a comment by Kimberly Applegate, who did a presentation yesterday about the issue of age, elderly women, and she says the age range from 12 years to 50 years is reasonable. Age 55, related to the question that was in the Q&A, is not necessary unless a special situation of artificial fertility. Menstruation to age 55 does not mean fertility. So just consideration. And I had another question, and it's, as I understand, most of the cases that you have to deal with at the end are cases where the doses to the fetus or to the embryo are low and are not particularly worrying for the fetus, so you don't expect many risks or damages to the fetus. But sometimes there are cases where the doses to the fetus may be relevant by, for example, in cases of radiation therapy or with radionuclides, for when the patient does not know to be pregnant and so on. And are there, in this case, guidelines, regulation, or how do you deal with the case when you have to tell the patients that the risk is high and there might be consideration of what to do with the pregnancy? Do you have some guidelines? Do you have some counseling? I think it's an interesting question. Probably you have different approaches in different countries. I will, so someone wants to answer voluntarily?
Actually, yeah, I probably can say something about it. So, as I said, we are stepping in after the damage has been done. So, a pregnant woman, got exposed knowingly or unknowingly and turns to counsel. So, usually the risk is not high enough the exposure is not high enough to pose any significant risks. So in most of the cases, basically close to any of the cases, there are no deterministic effects, and the stochastic risks are rather low. So basically, the physician in Germany can use anything he needs. He just needs to justify the procedure. And afterwards, we calculate the risk. The German law is very clear on that. We are actually not allowed to infringe on the woman's rights to decide the fate of herself and her unborn child. So it's her decision only. The only one she is consulting with is her gynecologist. So we are not allowed at all to infringe on that question at all. So the only thing that we can do is we can give information. What is the exposure and what is the risk following the exposure? And of course, these are numbers, and these are very often not really helpful. So we try to translate this into some understandable terms, and that's what the UNSCARE and ICRP are doing also. We translate into basically negligible, very low risks. And this is something that the patient can deal with, but we really have to refrain from saying anything about termination of the pregnancy at all.
Thank you. Someone else wants to share their experience?
I must say,
Dario?
I just wanted to say that during these 20 or years, in fact, our physicians, we never had a patient on radiotherapy that is pregnant. I remember one on chemotherapy, but I was not involved in this. So our physicians are very reluctant to have radiotherapy on pregnant patients. And in radiodiagnostics, almost impossible to have the doses that are close to 100. It's not impossible, but I have never seen it. It's not even 50. I don't have any experience where some special it's always about reassuring the patient. The doses that I met in my practice were always about reassuring the patient that the risk is not high. My experience.
Thank you. Yelena, you wanted to say something? I saw you have turned your microphone on.
Yes, thank you. So in Serbia, the situation is similar as in Germany. We don't have right to tell patients what to do, but we just have to inform them about numbers or risks. And we usually advise them to go to genetic counseling. And sometimes members of genetic counseling invite experts to further explain some situations if there are any. But only gynecologists and the members of genetic counseling have right to advise patients, but the decision is, of course, on patients, similar as in Germany, as I said.
I don't know if it could be helpful, but from our experience and from the study I mentioned, from the 269 cases of pregnant women, in 232 of them, the dose to the embryo was to the fetus was much lower than 10 millisievert. And only in 4 cases the dose was higher than 40 millisievert related to CT procedures. So just to have an idea about the range of the doses expected, especially from radiology procedures. Thank you.
Regarding dose from procedures, we have quite similar statistics. So in the 5 years that we looked at, we had only 2 cases with exposures above 50 millisieverts, and we had more than 40% below 1 millisievert, another 40% below 5 millisievert, and 25% of the cases were between or up to 50 millisieverts, and only 2 cases were above 50 millisieverts. And still, when you reach doses like that with, let's say, a couple of CT series, you still usually, or very often, you don't reach threshold levels for the deterministic effect. So that's basically, you can rule out. And in my experience, that's one of the major issues when we are asked for counsel. So the major fear of a pregnant woman that asks us is, will my child have malformations, and that usually we can rule out. We have very, very rare cases from radiotherapy, and in the one case that we had, we were supporting the radiotherapist to minimize the dose to the unborn child as much as possible. And I think we could support him as so far as to minimize the exposure to levels which allow the woman to still get the child, and which actually should not pose any significant risk to the child. With stochastic effects, of course, there is no threshold, so the risk will increase, and there are some concern that children are much more sensitive than adults. There is a factor that is proposed between 2 and 3, but still the dose range that we usually deal with are not really something to worry about. We then very often try to compare that to other risks that the child will face in their life or during their lifetimes, and that compared to those risks, the exposure will not be determining for the lifetime risk of cancer, for example.
Thank you.
Okay, maybe I can ask Dario one last question, if you don't mind. I know that in Working Group 12 of EURADOS, you are doing a questionnaire on about pregnancy and ionizing radiation. So what was the motivation? What are you planning there? Can you tell us something about this?
Your microphone is mute, Dario.
Okay, the motivation of this task, but also of questionnaire, was to see, in fact, see what different dosimetry approaches exist. Because if you look at the doses, you can see these doses that produce not really big risks. So sometimes one must ask himself, do we really need so accurate, precise, and also what are these softwares accurate, and how they are validated and everything else. So in fact, in this questionnaire, we wanted to see what approaches exist, dosimetry approaches exist, and then try to validate and compare these different approaches. In fact, why? Because maybe the doses mostly are low, but there are also high doses, and also typical doses are quite different, even for patient and also for pregnant patients. And also the doses that we estimate, in fact, come as an input to epidemiologic studies. So it would be much better if the uncertainties are the reason that these tasks exist, and questionnaire is just to see what approaches exist, how it is done in brief description.
Okay, so if there are no other questions, we can give the floor to Liliana for the exit of the school.
Thank you very much. I'm afraid it's time to slowly close our school, and on behalf of Scientific Committee and on behalf of EURADOS, I would like to say thank you to all the speakers for the first day and for the second day. It was really, they were really excellent talks, and we had a very nice discussion, even online, which is very difficult to maintain and to answer. Thank you for your time you spent preparing the presentations, but also for your time you spent trying to connect with us and trying to make sure that the connection is working. It was really a lot. We had a lot of problems, and I hope the audience was not able really to see it so much. And speaking about problems, I would like to also say thank you to our local organizers, online organizer, which will be a support team, to Babs and Kirsten. Thank you for being with us and for solving all the issues. That was extremely successful, and we are very happy that we managed to invite you to give to present all talks. And I would like to also say thank you for the audience because we had like about 400 people. That's really high number. We had a lot of discussions, a lot of questions, and I hope that we will stay in touch. And as we had 50% of non-EURADOS member, I hope you will contact us, find a proper working group 9 and working group 12. Dario, they are inviting. So feel free. Okay, more working groups are inviting. So feel free to contact us. Thank you very much for your patience. Thank you very much for participation. We will provide certificates for the winter school. So we will send to you by email automatically. And we are happy also to say that the winter school, 2 days of the winter school, they were accredited by IFOM. So that's maybe important for medical physicists. And also, I hope next meeting we will see each other, this time not online, but in reality, and we will be able to continue our discussion on this very important and very interesting topic. Thank you very much, and see you next year. Bye-bye. Thank you.